All right, everyone, thank you. I'll ask those folks coming in through the door at the end of the room to find a seat quickly. It's my pleasure to welcome you all back for this afternoon's very interesting session on all things hip related. My name's Claire Ardern. I'm a physiotherapist and an assistant professor at the University of British Columbia in Vancouver, Canada. And it's my pleasure to welcome my co-moderator and also your first speaker in this session, Dr. Mark Safran. Mark is an orthopaedic surgeon at Stanford University and is the chief of the Division of Sports Medicine at the university there, and also team physician for many, many teams. So Mark is very well placed to join us to kick us off to talk about how you might do a clinical assessment of the hip and for an athlete with hip pain. Mark, thank you.
Thank you, and thank you all for sticking it out for this last session on the hip, which is clearly the most important session, which is why they made it last, to keep everybody engaged. So I'm going to talk about the clinical assessment of the hip of the athlete with hip pain. And when I was a resident, basically, if you had somebody with hip pain and it was an adult, you looked at the x-ray, did they have arthritis or not? And if they didn't, they assumed it was just a groin strain or something and sent them on their way, which clearly our evaluation and understanding of the hip has come a long way in the last particularly 20, 30 years since Gans described FAI, and MRI has helped us see more pathologies in and about the hip, and I think our evaluation has improved. So first of all, hip pain is increasingly recognized in athletes, and I think the first thing you want to do when you're evaluating an athlete with hip pain is to determine, is it intra-articular or is it extra-articular? And the intra-articular causes of hip pain generally are labral tears, chondral injury, and ligamentum teres. And we tend to think of them as in two main pathophysiologies so that result in some of these damages. One is femoroacetabular impingement syndrome, and the other is hip microinstability. The extra-articular causes include hip flexor strains, adductor strains, greater trochanteric pain syndrome, which is a constellation of basically lateral hip pain, core muscle injury, and then the snapping hip. And so we'll just kind of go over how we evaluate for these. First of all, intra-articular problems, one of the key hallmarks is that patients complain of groin pain. But the key is you want to ask them, when they say groin, where are they talking about? And basically, we're talking about this area here. When you ask them to point to it, they'll often grab their hip, as you see with this individual, the so-called C sign, and they say it's somewhere between their long finger and their thumb and deep inside. They may complain of some catching, popping, or locking. And intra-articular problems tend to have discrete episodes of pain, particularly you can get some sharp pain occasionally with weight bearing, pain with prolonged sitting, so we see a lot of that with the people in Silicon Valley working on their computers, pain catching and arising from a seated position, going up and down stairs and hills. The key is that extra-articular problems, they tend to have pain more in the buttock, and so what I like to say when our staff is trying to screen if somebody wants to come and see me, I generally say, if they say they have pain in the groin, groin is good, butt is bad. So if they have butt pain, I generally try not to see them because that's not usually where intra-articular sources of hip pain come from. So posterior hip pain, lateral trochanteric pain, pubic pain, or pain that radiates to the groin, abdomen, or inner thigh. The real key is that, one, joint problems are not tender to palpation. So if they are tender to palpation around the hip, it's probably not coming from intra-articular. And then when you do your muscle resistance testing, that also should not be causing pain if it's intra-articular. The real key is, the observation is the physical examination. And you can start off by how did they sit? Are they slouching in their chair because they don't want to sit with their hips flexed 90 degrees or more? What is the positioning of their leg? Sometimes they're sitting on one buttock and not the other. If they have piriformis syndrome, you see that frequently. And when you observe them moving around in the office, do they walk with an antalgic gait? Do they have a Trendelenburg gait? You want to assess for generalized ligamentous laxity as well. We assess for a Trendelenburg sign, so I'll have the patient stand in front of me. I'll have my thumbs on their PSIS and my index fingers, if you will, along the iliac crest, and I'll have the patient stand on one leg and then the other. I can assess for both leg length discrepancy. I can assess for the Trendelenburg sign as well as for balance. And then you want to palpate all around the hip, particularly the muscular origins of the sartorius, the rectus, the glute med, and the adductors. You want to palpate the iliac crest for hip pointers, which you'll see frequently in sports like rugby and American football. Assess for hernias. You want to assess around the sciatic notch. You want to assess for the piriformis syndrome by palpating halfway between the ischial tuberosity and the greater trochanter. You want to palpate not just on the greater trochanter, where you might get trochanteric bursitis, but you want to also palpate on the gluteus medius tendon. I'll have patients laying on their side and try to do a bicycle maneuver, if you will. If they have external snapping hip, you'll be able to reproduce that with them doing that. You want to palpate along the pubic symphysis. You want to palpate for the iliopsoas. So one of the things that has been very helpful is Per Holmish has written a lot on this topic, and actually I think we see a lot of patients with anterior groin pain and anatomy of impingement, but in all reality they're tender over the iliopsoas, and the main issue is that they're weak in their iliopsoas and tender there. So you want to be able to palpate for the iliopsoas tendon. You want to assess range of motion. I tend to do this supine, though if you want to be more precise about your internal and external rotation and hip flexion, you probably want to do it with them seated. But I assess flexion, extension, ab and adduction, internal and external rotation, and then when you look at this patient on the bottom right, the question is the left hip tight or is the right hip loose? I don't know that you know the difference, but and when we talk about the original Faber test, which is also known as the Patrick test, where you have the patient in flexion, abduction, and external rotation, that's a test for SI joint pathology and or pubic pain, but that's also been used now to assess people looking at the height, if you will, of the lateral joint line of the knee from the table as a sign of stiffness. So here I tend to use my fist as just an internal measure that I carry around. You can use a ruler, if you will, to measure that height difference. We want to go ahead and do the labral stress test. So we flex, adduct, internally rotate, and extend the hip, and we can also externally rotate and extend as well. Basically, this is kind of like the McMurray's maneuver of the knee, trying to kind of catch the labral tear as you assess for pain. And then you can do the impingement test. You flex to 90 degrees, you internally rotate was my internal rotation test, then, but you adduct and then internally rotate. So it's flexion to 90, adduction, internal rotation. That should cause pain around the hip. And it's called the impingement test, but in all reality, it is not pathognomonic for impingement. It does give you a sign if there's some intra-articular pathology, but it does not necessarily mean that the patient has impingement itself. The hip instability test, you have the patient at the end of the table, their hip is hyperextended, they hold the other hip in flexion to kind of lock the pelvis. And can you turn off the sound on these videos, please? Thank you. So they're hyperextended and you externally rotate. That should cause pain anteriorly for a patient that has instability. The key that I see when people do this wrong is the patient's not far enough towards the end of the table and getting hyperextended. Another test, you abduct about 30 degrees, you extend, you externally rotate, and you apply an anteriorly directed force to the greater trochanter. That causes pain anteriorly as well for patients that have microinstability of the hip. And so if you have both of those tests positive, the patients have a greater than 95% chance of having an intraoperative confirmation of the diagnosis of hip microinstability. Then we assess things assess adductor strength, both with the hip and neutral flexion extension, and then you flex them up and assess for adductor strength and flexion as well. And then we'll do what's called the Hesselbach's test, looking for the so-called sports hernia, core muscle injury, palpating the rectus, the lateral edge of the rectus as it inserts into the pubis, and have the patient do a sit-up. That should reproduce pain. You check both sides. The other is doing a so-called resisted sit-up test, as you see here. The patient's going to do a sit-up, and we're going to try to hold them back and see if that exacerbates some of their pain down in the lower groin as well. Again, this is the true Patrick's Faber test. So the one buttock cheek is off the edge of the table. They're in a figure 4 position. You stabilize their pelvis with the hand on a contralateral ASIS, and then you push down on the knee and see if that causes pain. Posteriorly, you worry about SI joint pathology or SI joint pain. Patients with pain can hurt anteriorly and as well as potentially labral tearing. So psoas will also get flared up. Then you do the Ober test, assessing for hip abductor tightness. So they're laying on their side in a lateral decubitus position. You abduct their hip, you extend their hip, and then you try to let the hip fall into adduction. So when you do this with the hip and extension, you're looking at the IT band, but you can sometimes get a gluteus maximus contracture. So if they're stiff and can't go into adduction while in flexion, you need to be concerned about the gluteus maximus being contracted as well. You assess for the iliopsoas. Again, when I do my hyperextension external rotation test, you can also assess for tightness of the iliopsoas just up front. This is Per showing how to do a Thomas test with the patient at the end of the table. And then we assess seated hip flexion because that's how that's where the iliopsoas is more isolated in flexing the hip beyond 70 degrees of hip flexion. So we assess for iliopsoas strength while they're seated. Then I also assess for snapping of the hip. So you start an abduction, external rotation, and flexion, and then you adduct, internally rotate, and extend. That's one way to assess it. The other is to kind of do almost a labral stress test, but have the patient do it on their own. That basically you'll have the iliopsoas contracted, and that might snap over the anterior structures as well, looking for internal snapping hip. From an imaging standpoint, I like to get plain radiographs. I think you can't, for me, an MRI is really to help kind of confirm the diagnosis for most all joints, but in the hip, I think it can be even more helpful because the joint is so deep. But I think you need to start with plain radiographs. A CT scan if you're worried about bony pathology, and then other studies, I like to get an MR arthrogram, but a regular MRI is fine. The key for radiographs is that I think really paying attention to your AP pelvis radiographs being done properly. You can get a lot of information. I think you need to get an orthogonal view, some sort of lateral of the hip. A frog lateral is a lateral of the proximal femur. It is not a lateral of the hip itself, so it's not a lateral of the acetabulum, and so you don't get a true idea of the joint space posteriorly. I like to get a cross-table lateral, or false profile view can also help you. Again, a done view at 45 or 90 is only going to be a lateral of the proximal femur. You can also get an AP of the hip. I generally don't get that. But the key with the AP pelvis, you want to make sure the coccyx is centered over the center of the pubic symphysis, 1 to 3 centimeters over the pubic symphysis, and you want to have symmetric obturator foramen. And with that, you can see here the blue line is the posterior wall of the acetabulum. Sorry, it didn't, when it got reformatted on the computer that they're showing it, the lines aren't lined up. But you can follow the back wall of the acetabulum and the front wall. They should not overlap. When they do overlap, as you see in the upper portion, that is that's your so-called crossing sign. You look for sphericity of the femoral head. So again, I'm sorry, this got reformatted, so all these lines are off. You look for the femoral head being out of round. Here, this patient you can see has an old os, what some people call os acetabuli. These are actually rim stress fractures. And this patient, you can see the iliotial line at the is this line just medial to the cotyloid fossa. And you can see the floor of the cotyloid fossa relative to the iliotial line, looking for coxa profunda. So the frog lateral, as I said, is good for looking at the head-neck junction, but it is not a lateral of the acetabulum. So here you can see you draw a sphere around the femoral head, and you can see the pointer, all this is extra bone coming out around. So the anatomy that would put somebody at risk for CAM type of impingement. Again, I like a cross-table lateral. Again, the greater trochanter should not be posterior, otherwise you're not really getting a true lateral view of the proximal femur. And so here again, you can see some notching of the femoral head-neck junction straight anteriorly that you might get with pincer impingement. I like false profile view. Again, it gives you a better idea of the anterior coverage as well as looking at the joint space, particularly lateral. And so you can measure the anterior center edge angle of Lequesne. A CT scan, again, if you really want to get a better idea of the bony anatomy, here's an osteoid osteoma of a patient that had hip pain. I like to get 3D reconstructions, particularly when somebody has some unusual bony anatomy. This one you can see is an acetabular rim stress fracture that you didn't see quite as well on the x-ray. You see it very well on a 3D CT. I think when people are starting out doing hip arthroscopy, this could be very helpful as well to just understand the three-dimensional anatomy that you're going to be dealing with arthroscopically potentially. So 3D CTs I think can be very helpful. In revision situations, I get them routinely. And so this is a patient that had a chronic slip that went on to have continued problems and pain. And you can see they have a kind of a varus neck, and they were impinging as well. I get an MRI when I'm worried about soft tissue injuries or some bony stress injuries. So here you see a femoral neck stress fracture and a sacral stress fracture in our athletes. But I think an MR arthrogram is particularly helpful. You want to get an MRI that has a small field of view so that you get a better picture of really what's going on in the hip. An MRI of the pelvis is not nearly as helpful as an MRI of the hip, and an MRA I think gives you even more information. I think that MRIs are not as good with articular cartilage as they are for things like the labrum and other issues. The key is that I don't tend to use gadolinium in our MRIs as our contrast. I tend to use ropivacaine. because the incidence of asymptomatic labral tears is up to 60 to 80% of asymptomatic individuals have labral tears. So I want to know, is there pain coming from inside the joint or not? So I have them get ropivacaine, and then they get tested with an impingement test pre and post. And if they get significant pain relief, then I can feel pretty comfortable that their pain is actually truly intra-articular. So here's an MRI. You can see the femoral head is out around. You can see that the labrum is a bit rounded. You see some change at the labral chondral junction. You see some articular cartilage damage. And you see some notching of the femoral head-neck junction. So with this MRI, you can assume that this patient has combined type of FAI, both CAM and pincer FAI, which we'll be talking about later. I think you get other imaging modalities for snapping hip. If you really want to see it, you can do that with ultrasound. Ultrasound's really good also for looking at gluteus medius tendinopathy. And then we have judicious use of image-guided injections, again, to help kind of confirm the source of pain, as well as potentially to treat some of the pathologies. To allow rehab for iliopsoas tendinopathy, for instance, we'll have them get an image-guided ultrasound, image-guided injection with some corticosteroid. So I think a good history physical examination with a good AP pelvis and a cross-table lateral and an MR arthrogram with ropivacaine, I think you can get a complete workup on an individual. If they have some unusual anatomy or in a revision situation, I think a CT scan can be beneficial. So thank you. So next we have for a command performance, Rowena Johnson is going to come back up. She's a consultant musculoskeletal radiologist with expertise in diagnostic imaging, complex imaging, guided treatments in elite athletes. She comes from London, has a vast experience with musculoskeletal imaging in elite athletes. So Rowena, if you'd share some expertise with us. So thank you. She'll probably tell you why an MR arthrogram is wrong, but...
Hello, thank you for the introduction. There might be some repetition between what we say, but a lot of agreement. So I'm talking to you today about imaging and investigation of the injured hip. So as an outline, I'm going to go through the different diagnostic imaging modalities, talk a little bit about intervention, and I'm just going to focus on intra-articular pathology in the interest of time. So radiographs, it's very important to get radiographs in athletes. I think people often jump to an MRI, so they tend to go for cross-sectional imaging. There are certain things that we will see better in a radiograph, such as you can get a good overview of dysplasia. So say, for example, lateral uncovering of the femoral head, that we see much better in a radiograph than we would on an MR. Just as Mark had said, on the AP pelvis, the first thing you need to check is that the sacrum is vertically aligned with the pubic symphysis. And we really need to request this more, so you can sometimes see small ossicles that we can't necessarily appreciate on MRI. It's good for degenerative changes, avulsion injuries, myositis significans. So generally for mineralization, we will see that better on a radiograph. This is a very common radiograph that we'll see in a lot of hip-heavy sports, so with a CAM morphology, as you can see on both sides, which is a very common finding. I think the majority of hips that I report will have, in athletes, depending on their sport, will have a CAM and a labral tear. So it's also important to have a clinical context when you're reporting it. So this paper was a systematic review looking to see whether or not the type of sport influenced the morphology of the hip. Looked at 58 articles involving just over 5,500 patients, and it showed that you definitely have a prevalence of FAI across your hip-heavy sports, including football. The highest alpha angle is typically in the 1 o'clock position, and there was a positive correlation between the alpha angle and both the age and the activity level, as well as the prevalence of FAI in both the age and activity level. And even on asymptomatic signing MRIs, it's something that we see very commonly. The UEFA injury study was a prospective study looking at hip and groin injuries in professional football over 7 consecutive seasons. And what we saw is the most common injuries were adductor injuries, followed by hip flexor and iliopsoas. Intra-articular injuries in athletes are less common, so it was about 6% in football. And of these, approximately 3/4 of them are chronic overuse injuries rather than acute injuries. And that certainly reflects what I think myself and all my radiology colleagues would see when we look at the bulk of what's referred to us for hip imaging. So why does this matter? All of them seem to have, at least in this lower limb kind of population we're dealing with FAI. So one thing we'll see with it is the labral abnormality. So you get damage of the labrum, and that leads to early contact between the femur and the labrum. This can lead to reduced stability in the joint, and this will then subsequently lead to translational motion in the joint and shear forces in the cartilage and the labrum. So cartilage delamination of the acetabulum can occur with a CAM morphology. We do, however, see cartilage lesions in asymptomatic athletes, so there's always a bit tricky with knowing how to deal with them. But we certainly know that in elite athletes in the future have a higher prevalence of osteoarthritis and arthroplasty in the hip and the knee, even accounting for significant injuries in those areas. So I'll now take you through some images. So this is the MRI protocol that we use. So it'll be a 3-plane small field of view of the hip. We tend to use a 3 Tesla MRI. Proton density sequences are much better at looking at cartilage. Large field of view, we get a STIR for the fluid-sensitive sequence, which shows increased sensitivity compared to a PD FAT-SAT or a T2 FAT-SAT. And what you can see here is one of the most common findings that we see. So that tear, so a very subtle high signal cleft at the base of the anterosuperior labrum. So when I look at a labral tear, so I describe where it is using the clock face. Typically 3 o'clock will always be anterior, whether or not I'm using the right or the left hip. To talk about any chondrolabral separation, a paralabral cyst, and then the cartilage surfaces as well. What you can see here is that defect at the base of the superlateral labrum. Fluid is bright, whereas this is of intermediate signal. So that's fibrogranulation tissue. So that's not an acute event. That's a long-standing labral tear. What you can see with this case is this labrum, instead of having a well-defined kind of discrete cleft through it, is very degenerative, poorly defined. And what you can see there in the anterosuperior cartilage is a small fissure, a small full-thickness chondral fissure, and all this intense subcortical maroedema going around them. So I always have a very systematic approach to the way I report these, and I go through those methodically. This is more advanced degenerative changes. So MRI will typically undercall cartilage loss in the hip. It's much more accurate, say, for example, when we're looking at chondral surfaces at the knee or the tibio-talar joint. But what you have is, because the two surfaces are so flush with each other, it's easy to walk past particularly femoral head lesions, so you can have a delaminating tear in the femoral head cartilage. But because your acetabular cartilage is flush with that, we don't appreciate it. So we definitely know that MRI will undercall cartilage loss in the hip. What you can see with this athlete is that multifocal full-thickness cartilage fissuring, subcortical cyst formation. You can see that background CAM as well. MRI arthrograms. So at our practice, we don't tend to use them that often. We tend to do a very small field of view, high-resolution images of the hip. There are definitely some situations when it's of use, so particularly in the post-operative setting, where we'll routinely distend the hip with intra-articular anesthetic, same as Mark Safran had said he would do, and what that demonstrates is adhesion. So you do get some additional benefit from it, but we in our practice, find that with the majority of patients, we can just do a non-enhanced scan. What you can see there is the contrast undercutting the base of that labrum, so that's a recurrent labral tear in that area. Something else that's an option is the 3D MRI, so no contrast injection needed, which the athletes definitely prefer. Takes longer though, you're looking at 45 to 60 minutes depending on your scanner, but you get slices which are less than 1 millimeter, and you can volumetrically reconstruct them, and you get much higher resolution, in particular for the chondral surfaces, and definitely a better evaluation of both the cartilage and the labrum. So here side by side, I'm showing you an MRI arthrogram versus a 3D MRI. So on both of them, you can see that anterosuperior labral tear with a high signal. Here, we've had an intra-articular injection as contrast. But what you can see here is you can actually very clearly delineate the separation between the acetabulum and the femoral head cartilage. So much more appreciable information on the 3D MRI compared to the MR arthrogram. So this paper looked at the accuracy of an MRA versus a 3D MRI. So it looked at 50 FAI patients, 3D 3T MRI, 42% tears with a sensitivity of just under 98% and a specificity of 100%. With an MRA, 44 tears were identified with once false positive, sensitivity 100% and a specificity of 85.7%. So regardless of which one you're using, they are both good investigations, but you do certainly have some edges when it comes to the volumetric scan. This is another example I want to show you of a volumetric MRI. So again, you can beautifully see that full thickness chondral loss and that resultant bone on that area. This second case is an athlete who had a previous camera section. It's quite a large chunk of the bone that's been taken out. But what you can see, they had ongoing pain, is you can see that focal full thickness femoral head fissure with a little bit of fluid and synovitis next to it. So one of the downsides of MRI when it comes to looking at cartilage, so I said we miss things in the hip, but also we can only see cartilage when it's lost. And cartilage doesn't, the fact that you can still see cartilage in that area doesn't mean that it's normal. So MRI mapping techniques are another way of looking at this. So they offer the quantification of hip cartilage. T2 mapping is something that we did regularly when I worked in Oxford. So looking at healthy versus damaged cartilage, 3mm slices, 15 minutes, but to be honest, you can usually scan them a bit quicker than that. And what this looks at is the biomechanical alteration before you get structural changes in the cartilage. So it's non-invasive, potentially of use. Not many places do it routinely. Some departments do, but it's potentially of use to assess the efficacy of new treatments, and in the future may be a factor when it comes to disease prevention and modification. So here's an image, very exciting. We're normally very black and white and grey with our images, so finally a bit of colour from the radiologist. So what you can see here is what looks like a normal chondral surface in this patient, but when you look at the mapping, you can see some changes in the signal characteristics in that area, so that's starting to get early cartilage damage. So moving on to CT, so definitely superior for bony anatomy. We can reconstruct the images. Used a lot for preoperative assessment and post-op as well. Downside, obviously, is having a radiation dose. This is a rim fracture, so some people refer to it not as acetabular, but actually a rim stress fracture that you can see there. And you get a nice volumetric 3D image with that. This is another example of a reconstruction with heterotopic ossification used for preoperative planning. Radiologists don't particularly find 3D images that helpful for us. We prefer the raw data, and with CTs, particularly the axials. Our surgical colleagues love it, though. They like the 3D, and they particularly like spinning it around as well. So we always tend to provide them. It's like a kid in a candy shop when you get it up. So, yeah. Subspine impingement. So another example, again, this athlete had a previous avulsion injury at the anterior inferior iliac spine of their rectus femoris, and you can see that kind of bony remodeling and that protrusion in that area. Ultrasound, so final modality, so it gives us very good dynamic evaluation of the hip. For example, with a snapping hip syndrome, you can see the anterior labrum, psoas. We use it for intervention. This is actually a patient I saw just over a week ago. So what you can see there is they have an intralabral cyst, so very complex, kind of multiseptated. You can see it tenting the anterior capsule. And what you can see is the ultrasound equivalent of it there with the cyst, and you can see how thick and irregular the capsule is. And under ultrasound, we can aspirate and do a trepanation of that. So benefit of ultrasound is being able to have that diagnostic approach, and also to be able to perform interventional procedures or diagnostic injections at the time. So I have focused just on intra-articular pathologies, but just to say there is a very large range that you can see here of hip and groin conditions that can cause pain. Here we have an example of a femoral neck stress fracture, and it's also important to understand several conditions can coexist. So in conclusion, final thoughts. So there's a high prevalence of CAM and pincer type morphology and labral tears, even in asymptomatic athletes. If you have athletes with acute hip pain, you have to also image the periarticular structures. So you need to look for other causes of pain, such as the adductor, psoas, and the inguinal canal. And most importantly, treat the player, not the picture. So lots of things that we may see on MRI may not be clinically relevant. Thank you very much.
Thanks, Rowena. I'm going to keep us moving, and it's my pleasure to introduce my friend and colleague, Dr. Paul Dykstra, who's a sport and exercise medicine physician. He's also about to go through his PhD Viva on Monday at Oxford University, his DPhil Viva, all about treating pain in the athlete's hip, and we're going to hear a little bit more about that just now. Thanks, Paul.
Thank you very much, Claire, for that kind introduction. And yes, Monday morning, 9 o'clock, please think about me. But apart from that, I don't have any conflict of interest. I just want to thank you and thank Ian specifically for the invitation to be here today. I love Edinburgh and it's good to be back. This is where I work with Enda King. You probably know where this is by now, Aspinall Hospital, a FIFA accredited and IOC research center. I've been there for 10 and a half years, left the UK in February 2013. It's time to get back. My learning objectives for this presentation is hopefully after this talk you'll be able to apply appropriate terminology and language when communicating with each other and with athletes and patients. I think this is a huge issue in this field, as you hopefully will see just now. And to describe the natural history of primary CAM morphology. And I'll tell you a little bit more why I think this is really important. So, we are all labeled. We dish out labels, we label ourselves, and we label others. And dare I say that as healthcare practitioners, sport and exercise medicine physicians, orthopedic surgeons, physiotherapists working in rehabilitation, that we label patients and people when it's not helpful and when it's unnecessary. Dr. Sophia Jex-Blake refused to be labeled as a woman who can't study medicine. I love the medical history of Edinburgh. So she and 6 of her colleagues were the first medical students here at Edinburgh. And you will know, I took a picture of this plate at the entrance of this complex. There was a riot in November 1870 because they took their anatomy exam in the halls next door. And obviously fellow students and people of Edinburgh were not happy that women were allowed to take to study medicine and to take the anatomy exam next door. But she refused to be labeled as a woman who can't be a doctor. Now, what would you label this person with? Fastest athlete in the world, multiple Olympic champion, world record holder, 100 meters, 200 meters. Name it. Exactly. Or a person with scoliosis. And this is a tweet by Usain Bolt. Couldn't let scoliosis stop this dream. I want to argue that FAI, or femur-acetabular impingement, labels healthy people, and we should abandon this term. Therefore, the topic of my talk is not the natural history of FAI, but of primary CAM morphology. And hopefully I'll convince you. The history of the FAI, or the term FAI, is about 20 years old. So Professor Guns from Switzerland defined FAI as an abnormal contact that may arise as a result of either abnormal morphological features, and I colored abnormal there twice, or as a result of subjecting the hip to excessive and supraphysiological range of motion. Others before him has used the tilt deformity. Dr. Murray, who was a radiologist practicing in London in the 1960s. But also Professor Solomon, I learned the other day, who practiced in Johannesburg at Wits University, used the term tilt deformity in a wonderful publication in 1976. And I won't go into detail in the interest of time. But also the pistol grip deformity has been used by, I think it was coined by Stulberg in 1975, but also used by many others, including Harris et al. In 1986. So I was part of this panel of 21 men and 2 women in Warwick, who, and we agreed on the terminology to use for FAI syndrome. And this is the terminology that we should be using when we are discussing patients, so people with symptoms, FAI syndrome specifically, and when we discuss the morphology, CAM morphology and pincer morphology. And terminology to avoid are asymptomatic FAI, symptomatic FAI, FAI morphology, deformity, abnormality, or lesion when referring to CAM or pincer morphology. So this is the agreement in 2016. Building on this work, and as part of my PhD, we got together a much larger panel in Oxford, so-called Oxford Consensus Study, including patients, and 11 orthopedic surgeons, 10 patient and public involvement group members, 17 physical therapists, 13 physicians, 6 radiologists, and 8 researchers. So 65 panelists who scored 85 statements, 12 definition statements, 19 terminology statements, 4 taxonomy statements, 12 imaging outcome statements, and 38 research statements that I'll discuss in my last presentation of the day. And when describing this hip condition, we agreed with the Warwick Agreement that we should use the word morphology when we are discussing a bone or cartilage bump at any location around the femoral head-neck junction. I'm not expecting you to read this, only the yellow bits, and we agreed with Warwick to avoid, never ever to use lesion, deformity, and abnormality. So you have ammunition now. If someone in whatever format use those words, you are, well, not allowed to shoot, but you can shoot him with words, or her with words. Don't use that. And we also agreed that femoroacetabular impingement syndrome with CAM morphology is the preferred term to use for hip-related pain due to a bony bump at any location around the femoral head-neck junction. Terms with tension from this consensus are CAM-type impingement, CAM femoroacetabular impingement, and CAM-type femoroacetabular impingement. And our radiology and orthopedic colleagues still use these terms. But I hope I've convinced you that there's enough evidence to avoid FAI or femoroacetabular impingement, because this labels healthy people with a condition that they don't necessarily have. And to use my friend Hans Toll's words, I would say bye-bye FAI. Hans Toll said bye-bye MRI in the hamstring context. So I would say bye-bye FAI. Classifying the morphology was an important aim for us as well. So we asked the panelists to score 4 classifying statements, and we agreed that we should distinguish between primary and secondary CAM morphology. So primary CAM morphology will be the topic of the rest of my talk, and this morphology has 5 important conceptual but also operational attributes. First, tissue type, can be either bony or soft tissue. Size, it has a location or a specific site around the femoral head-neck junction. Shape, and ownership, which I will discuss a little bit more. So, distinguishing primary from secondary CAM morphology, primary CAM morphology develops during skeletal maturation as a normal physiological response to load. And I want to emphasize this, that it's a normal physiological response. We agreed on this. There was some tension in the room around the word normal. So I think more work is to be done around that specific word in this statement. But I think it's a good way, and I certainly use this when I communicate with my patients, that what you have in your hip is normal for you as a football player and or an ice hockey player. So the full definition of primary CAM morphology is it's a cartilage or a bony prominence or bump. And interestingly, in 1965, Murray also used the word bump, of varying size at any location around the femoral head-neck junction of the hip, which changes the shape of the femoral head from spherical to aspherical, and it occurs most often in asymptomatic male athletes in both hips. And this might be because we don't have a lot of research in girls and women. So it develops during skeletal maturation in young adolescents with no current or previous hip disease, this is important, as a normal physiological response to high-load sporting activity and other unconfirmed risk factors. What I'm going to discuss with you now is published in the British Journal as well as an infographic. So based on our Oxford Consensus, an infographic of the natural history of primary CAM morphology to inform clinical practice and research priorities. And I'll just run through a few important aspects of this. I want to commend Claire and JOSPT for publishing a wonderful paper a few weeks ago. The first author is noted there. How do you pronounce his name? Lossiel, et al. In 2023, discussing the haphazard and, in many ways, inappropriate use of risk factors in research and in communication, and urging the appropriate use when we talk about risk factors or markers of risk. So when we have only descriptive research to back the association between a variable and an outcome, we should use the term a risk marker. When we are sure that there's a causal relationship, we can use the term causal factors, and especially when we do that in causality research. So a few words on what causes primary camouflage. This is a wonderful study that Jonasson et al. Did in 2015 on the proximal femurs of 7 piglets or young pigs of 5 months old. They loaded these pigs vertically and anterosuperiorly and showed that this damaged the growth plate and the tissue around the growth plate. I won't go into too much detail about that. And these are the only 2 large prospective cohort studies in sport on the camouflage or primary camouflage development by the Southampton-Oxford collaboration, Anthony Palmer and Scott Fernquest, and the Feyenoord Erasmus University partnership, Rintje Agricola and Pim van Klaai, who published wonderful cross-sectional but also prospective cohort publications on the work they've done. And I'll focus only on the Oxford study for now. I don't have time to go into the other one, but this is the cross-sectional figure from Anthony's paper in British Journal of Sports Medicine, indicating that there's a relationship between the maximum cartilage alpha angle, the first time that cartilage alpha angle was described in the literature, and age. And you'll note there that for those who didn't participate in sport, no sport, this remains sort of a flat line, so the alpha angle doesn't increase. Whereas those who participate in school and club sport, there's a slight increase over time in the alpha angle. Remember, this is cross-sectionally. And in the football academy players, they had the largest increase in alpha angle around the age of 15. And after that, it plateaus and nothing much happens. And this is also from Anthony's paper, a 16-year-old football player with pronounced camouflage at the 12, 1, 2, and 3 o'clock positions, as Rowena alluded to. And the maximum epiphyseal extension is at the 1 o'clock position, as you can see there. And this is just an illustration of what we mean by the clock face when we do MRI scans on the hip, with the 3 o'clock position anteriorly, as Rowena mentioned. And this is the prospective cohort publication by Scott Fernquest of the same data. So over time, the largest difference between baseline and follow-up after 3 years alpha angle was in the elite football group, and statistically significantly different between the elite football group and the male and female controls. And also for physical activity, measured as the physical activity questionnaire here. So the largest difference between baseline and follow-up alpha angle was in the highest physical activity group on your right. So physical activity during adolescence is strongly associated with primary camouflage development in males and quantification of what they call the pathological physical activity. Maybe not a nice word, pathological physical activity, or the physical activity that might inflict the morphology or damage, and type warrants further exploration. And this might help us to screen and also to intervene in future. We're not there yet. So girls probably develop this morphology between the age of 9 and 10, 11 maybe, and boys between the age of 11 and 12. And after the age of 14, nothing much happens. So if you don't have primary camouflage by the age of 14 or 15, you probably won't get it. There might be exceptions. This was also demonstrated in a nice little study by Marcus Hanke on elite adolescent ice hockey players. At baseline, nothing at 12 years on your left, and developing into a camophology after 3 years in the scan on your right. And at 3-year follow-up, 6 of the 22 players in this ice hockey cohort had either pain on the Fader test and or a restricted hip internal rotation below 20 degrees. The important message here is that there's no prospective research on primary camophology etiology in young female athletes at all. Now, what happens? What are the consequences or the possible consequences of primary camophology? And we want to argue that in the vast majority of athletes, nothing much happens. They will continue to perform with their happy hips, and in fact, the vast majority will never know that they have this morphology. And this was, in a way, demonstrated by Andrea Mosler in her study in the Qatar Stars League 2-year prospective cohort study. 84% of hips defined as having primary camophology never became painful over the 2-year period. But there's also hip disease consequences, subclinical hip disease, as Rowena alluded to in her talk, but also clinical hip disease and hip osteoarthritis. Josh Heary's nice study in a cohort of symptomatic and asymptomatic football players demonstrated that camophology size was associated with cartilage defects and labral tears in young adult footballers with and without pain. And I think this is important. So the key question looking at osteoarthritis is primary camophology a risk marker associated or a causal factor for hip osteoarthritis? And you all know these two wonderful long-term prospective cohort studies, the Chingford and Czech studies involving large cohorts of mainly women, demonstrating that there's a strong relationship between the alpha angle in the Chingford study above 65 degrees and in the Czech study above 60 degrees and 83 degrees and osteoarthritis. In fact, the adjusted odds ratio is 25 when the alpha angle is above 83 degrees and combined with an internal rotation of less than 20 degrees. But again, the question, is it an association or is there a causal relationship? To decide whether the most likely interpretation of the association between two variables, CAM, morphology, and OA is in fact causation, one would have to consider and satisfy Hill's 9 criteria for causation. And just to remind you, these are Hill's 9 criteria for causation. And this is exactly what Professor Paul Boulay did in a wonderful publication, Unraveling the Hip Pistol Grip, CAM deformity. So the only thing that I don't like is the terminology in the title, but and origins of hip joint degeneration. And satisfying all 9 Hill's criteria, we can conclude that primary camophology is a causal factor for hip osteoarthritis. So I've mentioned this is the publication. There's much more in the British Journal. It's open access, so scan the code and read if you'd like. Primary camophology and its natural history. In summary, FAI labels healthy people with a disease or a condition. Primary camophology is distinct from secondary camophology and develops during adolescence as a normal physiological response to load. Primary camophology is likely inconsequential in most people. It is a risk marker for asymptomatic hip disease and FAI syndrome and a causal factor for osteoarthritis. We need more research in girls and in women. Now, I love this quote from the 1869 publication by Dr. Sophia Jex-Blake that I've started with. And this was part of a book published in that year by Josephine Butler, Medicine as a Profession for Women. No thinking man will pretend that the world has now reached the zenith of truth and knowledge and that no further upward progress is possible. On the contrary, we must surely believe that each year will bring with it its new lesson. And this is certainly true for women in this field of research, for women at the time when Dr. Sophia Jex-Blake studied medicine, and certainly true for the field of primary camophology, FAI syndrome, and hip osteoarthritis in the athletes specifically. I want to thank everyone that contributed in many ways to the research that I've presented here, and it's my opportunity to, by name, thank Claire, who's been heavily involved in this process, because she's on the podium here. Thank you very much for listening.
I'm going to suggest we make a slight change to the program and continue with our speakers. But before we do, I would like to ask you all to stand up, take a 20-second stretching break, and then we'll move on to the next speaker. All right, so we're back, everyone. Could I ask the AV folks to turn on one of the other podium mics, please? Thank you.
All right, to get us back on time, we now have the pleasure of having Paul Gaston come and present to us. He's a graduate from the University of Edinburgh Medical School, as well as doing his surgical training and orthopedic training both here and then in Oxford, and did his fellowship in Brisbane, Australia. He came back to be as an arthroplasty surgeon here, and it's what we see different from the United States. He is a complete hip surgeon because he then expanded his expertise into hip arthroscopy and was one of the first in Scotland to be doing a hip arthroscopy, and he'll be sharing us his treatment considerations for the athlete hip pathology. So without further ado.
Thank you. Thanks for the introduction, and thanks for inviting me to speak, Ian and Paddy. So before I get going, I'd just like to ask Paul Dykstra if he's got his gun with him, because he's going to need to shoot me for some of the words that I use in this presentation. Luckily, this presentation is short, so we should keep to time. My only disclosure in this field is that I'm a member of this organisation, the UK Non-Arthroplasty Hip Registry, which is a fantastic thing, and I would urge any UK surgeons in the room to use it because it allows us to collect data and reflect on what we do. So, we've heard about the clinical presentation. You see an athlete with hip pain. Here is the C sign. He's pointing mostly at the front. I would ignore these fingers on the back. And I entirely agree with Mark Saffron. If it's a pain in the butt, it's not a pain in the hip joint. Then, if you're lucky to have someone like Rowena, you might get these beautiful images. I have used the S there, Paul, so hopefully you'll let me away with that one, although that needs to be deleted and the word morphology put in there. So you get your beautiful images, possibly 3D reconstructions. The patient's got a labral tear, they've got the cam. You put it all together and you think, yes, this patient likely has femoroacetabular impingement syndrome. So what are the options for management? And I'm sure you all know what they are, but here's one that's in all the medical student textbooks, although we're not allowed to do that, the so-called do nothing at all. And athletes and patients really don't like that, because why do you think they came to see you in the first place? They want you to help them get better and get back to the things that they want to do. The next option would be so-called best practice or specialist physiotherapy, especially for the professional athletes or anybody doing regular sports. And our professional athletes are very lucky that they have a lot more access to this than the average person off the street. And then, of course, one of the dangers of coming to see an orthopedic surgeon like me or Mark or any of the other orthopods in the room is that if you turn up at the clinic, you might get an operation. So be careful what you say to orthopedic surgeons is what I would advise. Now, why do a hip scope? Anybody got any ideas on that? Because it's fun. Look, here's me. I'm really, really happy. I've got my tools in my hand. The screen's over there. Look at that hip. You can see how, though, it's absolutely no fun for anybody else because they completely abandoned me and left the room to let me get on with it, yeah? So they're all like, oh, God, Gaston, when is this going to finish? But does this operation actually work? And how do we prove that? Well, the best way to do it is with randomized controlled trials comparing the surgery to other treatment options. And so we're very lucky in the UK. So here's where you are today up here in beautiful sunny Edinburgh with fantastic weather. But in the UK, we've actually had two centres, one in Oxford and one in Warwickshire, who've set up these fantastic randomized controlled trials in this field to help people like me justify what we do and prove that what we do is a good thing. And so the one from the Warwick group is the Fashion trial. The Oxford group was called the Fate trial. But in fact, there have been several other RCTs published in this field around the world over time. These are the results from the Fashion trial published in the Lancet in 2018 by Griffin and his whole group. And what I really want to draw your attention to, especially for the physios in the room, because often when I give this talk to physios, they get really cross with me because they're like, Gaston, you need us as well. But that's the point of this study. The patients in red had a hip scope on their journey but they also had all the other treatments that the patients in blue had, and the only thing is the patients in blue didn't have an operation. And you can see that actually for the first 6 months, there's not really that much difference between the two groups. But by a year, there's a clear difference between the patients who'd had surgery in their journey and the patients who'd had specialized physio alone. The difference was statistically significantly different, but also this difference met the minimum clinically important difference. In other words, the patient could tell that they were better than they'd just had rehab alone. But the point I'm really making about this study is that it takes both sides, and patients have to do both to achieve the best outcome. More recently then, the same group have published a big review and meta-analysis article on all the different randomized controlled trials in the field of hip arthroscopy. And basically the summary is arthroscopic hip surgery offers better early patient-reported outcomes than targeted physiotherapy for FAIS. And so I think now in terms of science and data, there's not that much doubt that this operation can make a difference for patients. We also looked at quite a lot of data here locally based on all the patients that were put into the non-arthroplasty hip registry, and a lot of this work was done by Paddy Robinson, who's in the room, and some of my other colleagues, and I'm very grateful to them for their help over the years. We found that at 12 months, 79% of patients were either satisfied or very satisfied with the outcome of a hip arthroscopy, 10% were dissatisfied, and there was a group in the middle of about 10% who were a bit like, not too sure, doctor. And I actually use this data now to counsel my patients. So I say to them, there's an 8 out of 10 chance you'll be really pleased with it at a year post-op. There's a 1 out of 10 chance that you'll not be that certain. And there's a 1 out of 10 chance that you'll not be happy with the outcome at 12 months. What we did find, though, when we drilled into this data more deeply, is that younger patients did better than older patients. So under 30s had higher scores, and in fact, on this IHOT 12 score, reached the ceiling of the score very, very quickly in a lot of these cases. We also found that, and this was quite surprising because I really thought it would be the other way around, that the scores after a hip arthroscopy keep improving over time. So even after 12 months, patients still get better. The scores keep going up, and even at 5 years, they're better still. And actually, I've noticed that anecdotally, that I hear from patients way down the line that their hip's doing better than ever. We then performed a survivorship analysis of a cohort who'd had at least 10 years since their operation, and roughly 80% had not had to have another operation in the 10 years following their hip scope. And it's probably about the same 80% who were satisfied with the outcome. So what are the predictors of an outcome after hip arthroscopy? And this is another big review article written by Vikash Kanduja, who's the new president of the British Hip Society, heavily involved in arthroscopic hip surgery and teaching. And this piece of work includes data from 90,000 patients, so it's quite hard to argue with. This is what they found. Who does well? Actually, athletes. So anybody sporting does a lot of exercise, and professionals even better for some reason, except ice hockey, and I don't know if that's been your experience, you guys who work in the States with ice hockey players. And also then, if they have a good response to a local anesthetic injection, and that's not with steroid, just local, they have a good chance of doing well after the operation. But this is probably more important for sort of everybody to be aware of. Who does badly? If there are any signs of osteoarthritis in the joint, so either subchondral cysts or lateral joint space less than 2 millimeters, older age group, and sadly this includes me and a lot of people in the room now over 35, and then all these other little factors, dysplasia, if they have a big cam, psychological factors, inflammatory arthritis, and the usual obesity, smoking, and alcohol. So just to illustrate a point here, I would say that osteoarthritis is a no-no for hip arthroscopy. Now, can anybody see anything on this x-ray? It's the right hip that's sore. No, nothing really to see here. It doesn't look too bad. Good joint space. But you get an MRI scan, and the patient's got these little row of subchondral cysts right in the weight-bearing area of the acetabulum. And no arthroscopic procedure with the best will in the world can make that better. What about predictors of return to sport in athletes after hip scope? So these two great review papers, one from the States and one from Europe, and they pretty much say the same thing, and really interesting. So they have actually a slightly better recovery and return to sport than the lay public, where 88% returned to sport, 12% did not. Multiple reasons why they didn't, and interestingly, of course, because they had ongoing symptoms. In the European study, it was very similar. 87% returned to sport, 82% at their previous level. Professional athletes did even better than recreational athletes. And in those that didn't get back to their sport, the problem turned out to be that they had cartilage damage in the weight-bearing area of either their femoral head or their acetabulum, or they already had osteoarthritis. Athletes do better than, I think, ordinary patients. One of these athletes had a hip arthroscopy, then won a gold medal at the Beijing Olympics. One of these athletes had a hip arthroscopy, then scored the try of the tournament in this year's Six Nations. And this athlete sent me these pictures just recently, and she had a hip scope on the left side, so the leg that she twists into, there she is with the driver, the iron, the putter, and the raised fist on the 18th green. And she sent me this little thing that I'll just let you read out for yourselves. Apparently this was a new tournament, the Rose Trophy, which is a one-day tournament for ladies organized by Justin Rose and his wife. So in summary, and this would be my take-home message, if you define it properly using the correct terminology, Paul, hip arthroscopy works in femoroacetabular impingement, especially in the athletic population. However, and Rowena demonstrated it beautifully in some of her images, if there's surface cartilage damage or cysts, you've got to start thinking, wait a second, can I actually help this patient? If there's osteoarthritis, then this operation will not work, and I would suggest you shouldn't embark on it. Thanks very much, and I hope you've had a good time in our city.
Thank you, Paul. And I should have said earlier, please hold your questions for the first block of speakers. We will have a all-star panel discussion at the end of this block. So hold those questions for the panel discussion or the coffee break. Now it's my pleasure to introduce Mark Safran back onto the stage again. We're shifting from primary care morphology, femoroacetabular impingement, and now talking a bit more about the labrum and hip instability. Mark.
Great, thank you. So I'm going to talk about what we do with the labrum when it's symptomatic and torn. Do we remove it, repair it, or reconstruct it? This is, if we can get the clicker to work. There we go. So we know the labrum has a lot of functions. So some people used to think of it kind of like the appendix of the hip, or the meniscus, if you will, and the knee originally from the 60s. In all reality, it has a lot of functions. It's a joint seal. It helps provide lubrication to the joint itself, allows for cartilage nutrition. It's important for stability and depth of the socket, as well as maintaining negative intra-articular pressure. It's important for load sharing. So if you see this upper drawing, what you have is actually fluid within the articular cartilage. When you compress the joint, the labrum is more impervious to the fluid than the cartilage itself, so it actually will maintain or resist cartilage deformation. Without the labrum, you get the fluid coming out of the labrum, you get more deformation and increased stresses. We also show that if you actually resect the labrum, that it takes more force to initiate rotation of the joint, so there's more friction, if you will. And then we know that the labrum has some mechanoreceptors for proprioception and has so it has all these different functions. So I think the goal when you have a labral tear is that you want to try to preserve the labrum if at all possible. Now, as I look at it, the labrum is usually a victim. As I said, 60 to 80% of asymptomatic individuals over the age of 18 who have no hip pain have labral tears. So when there are symptomatic labral tears, usually there's another issue or cause for that. So I think you need to address those causes. If you look at some of the literature from the past, which we'll get to, if you just address the labrum, you generally don't have a vast majority of patients that are happy. Some yes, but not. Others not. And I think you need to look at what is this underlying cause. Do they have impingement? Do they have dysplasia? Do they have instability? Do they have iliopsoas issues that may be causing it? So when you look at the literature from the 90s, before we had ever heard of FAI, at least in the States, 60 to 95% of individuals that had arthroscopic labral surgery had improvement. And so the question is, why only 60 to 95%? Most of those were in the 60 to 70% range. And maybe it was because there was untreated FAI. And when you look at Tanzer's work, where they had only 25% success rate of partial labrectomies, they went back and looked at their patients, and 97% of those individuals had the anatomy, if you will, of impingement itself. So they had cam or pincer morphology. When you look at another retrospective study of 43 patients that had arthroscopic partial labrectomies with almost 4-year follow-up, those who did worse were those that had the anatomy of impingement. So that could certainly be part of the cause. When you look at a study from Ricky Villar, he looked at 71 hips that had CAM FAI anatomy. It was a retrospective sequential series where those that he did just partial labrectomies, there were 47 hips, just over half were females, 60% good excellent results, and 26% poor results. Whereas those that he did CAM resections along with doing a partial labrectomy, there were 24 hips, 42% female, but again, 83% had good excellent results and only 13% had poor results. So that he suggested that you need to actually address the labrum at the same time you need to address the CAM morphology. So you need to address that, and even further research that has come out more recently with newer technologies that comes from the McMaster group, Femi Ayeni, who did the so-called FIRST study, which was also a prospective randomized controlled trial of 220 patients that were ages 18 to 50 years of age, so your classic patients that we treat in an active population. Half the group got arthroscopic labral surgery, generally that would be labral repair, some debridement, and half the group got it with a CAM resection, and half did not have an osteochondroplasty, so just the labral surgery itself. Those that had the FAI surgery had a higher, that did not have the FAI surgery had a higher reoperation rate. They both did good initially for the first 6 months to a year, but at 2 years, a lot of those patients that only had the labral surgery and did not have the CAM resection ended up coming back for more surgery because of persistent symptoms. So it's important to realize, though, that the labrum has limitations in what you can do as far as repair. It has a poor capacity to heal due to its limited blood supply. Most of the blood supply comes from the capsular side. As you can see from this study, I've actually demarcated the labrum itself. You can see this is an India Ink study, and here's blood supply, and you don't see really much within the substance of the labrum itself. So intrasubstance labral tears have limited capacity to heal. Unfortunately, it looks, well, so this is just showing some pathophysiology of how we think pincer impingement works. With an overhanging acetabulum, your labrum is going to get crushed at the head and neck junction, and then you'll also get this contracute deformity, so you get some damage down contralaterally. But what's happening to the labrum? The damage pattern to the labrum is a crushing, usually intrasubstance labral damage, and those tend to be difficult to treat. It tends to be crushed, it's intrasubstance, and with a limited blood supply, it doesn't have much capacity to heal, and trying to sew that up may not actually do a whole lot either. So what do we do in that scenario? Well, you can go ahead and do a debridement or partial labrectomy. You can use these little meniscal biter type instruments like a Pac-Man to resect part of the labrum. You can use a suction shaver. So here you can see some articular cartilage damage along with the torn labrum being removed with a suction type shaver device. Or you can use a radiofrequency device. Here you go. A radiofrequency device, and here we just have a labral tear at the labral chondral junction and just kind of ablate that tissue. But again, I think we try very, very hard to try to maintain the labrum if at all possible. But one of the questions that always comes up is, well, I mean, isn't the labrum important? And certainly I see a lot of patients who come to my office who say, but I have a labral tear, and I try to explain to them that a lot of asymptomatic individuals do, and their pain wasn't necessarily coming from inside the hip. But the question is, if you don't repair it, what else should you do? And so the general thinking was, well, we don't try to repair the ones that can't heal, so you can do a partial resection, as you see here. The problem is, what is the outcomes of those? Interestingly, we did a study with Hassan Sadri in Switzerland, who trained under Gans. He did open FAI surgery, but when you do that, that surgery is an open procedure. You have to do a trochanteric osteotomy. Then you fix the trochanteric osteotomy with screws. patients don't like their screws in the trochanter. So at 2 years, routinely he'd take out the screws, and at that time he was learning hip arthroscopy, so he went ahead and scoped the hips. And what we found is that the labrum actually regrows. So he had 24 patients that he did an open resection. There was no question that he removed the labrum. These patients averaged 29 years of age. And again, they had the open FAI surgery 2 years later to have the hard removal. And what he found was that in 21 out of the 24 patients, they actually had tissue that was indistinguishable from the labrum around it, but there was complete circumferential growth of the labrum to the same size as the normal labrum. And 3 of the 24 had some regrowth, but it wasn't as thick as the normal labrum itself. So we don't know about the biomechanics of this tissue. We don't know if it functions like a normal labrum, but there's clearly some tissue that grows back there. Now, CAM type of FAI impingement, the pathophysiology is where the loss of sphericity of the femoral head neck junction causes a labral chondral separation initially before it butts against the rim of the acetabulum. So what's happening is that you're initially sparing the tissue itself within the labrum. You're causing a labral chondral separation. This is your femoral head and your acetabulum. You can see I'm going to try to pull this labrum up out of the way, and you can see the edge of the acetabulum there. In that scenario, I think you can rely on the blood supply from the rim to allow healing of the labrum back down to the bone. So with that, we want to do a labral repair, and so this is just schematically what a labral repair would look like. But when we look at, with a labral repair, if you don't do any bony surgery, is that scenario common? In all reality, it's not. Again, usually there's something else going on, be it dysplasia, instability, or FAI. So in those scenarios, do you see really primary labral tears that require repair? And so Tom Bird did a study looking over 4 years of over 1,500 hip arthroscopies. He found only 37 patients with 38 hips that actually had just primary labral repairs, and he had 439 that had a labral refixation, so that was he detached and had to re-repair. So really only 8% of all labral repairs that he had were primary labral tears that needed isolated repairing. Usually, again, it's associated with other issues. And so when we repair the labrum, there's different techniques that you can use. You can actually go around the labrum itself with a suture all the way around. To me, I think that pulls the ball away, the labrum away from the ball. And so you lose that suction seal effect, whereas if you do kind of what we call a base fixation here, that leaves the free end of the labrum free to be able to sit over the femoral head and restore your seal. And so we tried to study this in the lab, and you could see the difference between this one, which would be a circumferential, take a stitch all the way around the labrum, and if I draw a sphere around it, you can see there's a gap right up and through here, whereas if you just do a base fixation, you maintain that sphericity of the labrum itself along its free edge. And then you can see arthroscopically, the same thing happens. You see a gap between the labrum and the femoral head when you go around the labrum with a suture versus a base fixation. You can see the labrum sitting right on the femoral head itself. So I think restoring the seal is important, and and I think a lot of people talk about the so-called suction seal effect, and so why you should have some tissue there and not leave a patient with a partial labrectomy. And so, there's a lot of debate as far as whether or not the repair pattern makes a difference or not, but we found that if you did a partial labrectomy and tried to distract the hip, there was 40% less force necessary to pull the femoral head away from the acetabulum, 25% less when you did a suture around it, and 22% if you use that base fixation technique. Other biomechanical data basically shows in the lab that the suture around the base is better than actually going all the way around the suture, but clinically it doesn't seem to make a difference. Right? We're not able to detect the difference. So Mark Philippon and the group at Vail looked at the effect of other types of things, not just labral repair, but he looked at labral reconstruction, which we'll get into. When you don't have any tissue to repair, he'll try to replace that tissue with another tissue, and he found that with the intact labrum, the ability to pressurize the joint with the labral reconstruction is as good as intact, but repair is not as good as a reconstruction, and partial labrectomies did the worst. And so when we look at clinical outcomes for labral resection versus repair, one of the first studies done from the Swiss group looking at labral repairs in FAI surgery, this was done open. They had 25 patients with labral resection. They had only 28% excellent and 48% good results, and 24% were poor, fair to poor. versus 35 that they did reattachments, of which 94% of those patients were good to excellent. So those patients did better if you repaired the labrum versus resection, and fewer signs of osteoarthritis and a faster recovery in those patients. Ernest Childers, though, came up with a nice study at 101 patients where he compared resection versus repair, minimum 2-year follow-up, 75% were men. There were 2 groups. There was the labral detachments that he were able to repair and the labral flaps that he debrided. And so when you look over here at the outcomes, the patients in both groups improved, but the improvement was significantly better in patients that had a repair versus resection. The problem is, if you delve further into this, that you looked at the associated pathologies in it, and you find that the patients that had a repair had much lower incidence of full-thickness articular cartilage delaminations, and what's already suggested is that patients with articular cartilage damage don't do as well with hip arthroscopy as those that have intact cartilage. So that's a confounding factor that I think makes this difficult. So they're not really equivalent groups. The resection group had more advanced or worse pathology, so you'd expect them to do worse regardless, and that the chondral damage is associated again with the poorer prognosis. Chris Larson did a study comparing labral debridement with repair itself as well, 44 hips, and he found that the most recent satisfaction, they had a 68% good to excellent results at a minimum 3-year follow-up. When he looks at the refixation group, there were 50 hips, and you look at the outcomes that he had 92% good to excellent results. So again, suggesting that repair is better than removal. And then finally, there was actually a randomized controlled trial, only 36 hips with patients that had pincer type of anatomy and combined FAI. And they did labral debridements in 18 women, average age was 39. They had 78% good to excellent results, but 17% were abnormal and 6% were severely abnormal, so 23% not really satisfactory outcomes with the debridement. When you look at the labral refixation, also 18 women, similar age, they had 94% good to excellent results and 6% abnormal and no severely abnormal. So again, suggesting labral fixation is better. When you look at a systematic analysis of this, 4 of the 5 studies that compared repair versus debridement showed better outcomes with repair versus debridement. 1 showed no significant difference, but again, the studies are highly variable in how they're assessed. A couple things about this: when you look at labral repairs, the prevalence of labral repair surgery is going up and continues to go up. This is looking at American surgeons sitting for their boards after 2 years in practice, and you can see that 80% of hip arthroscopies by the end of the study of 2015 were getting labral repairs as part of the surgery. Now, it all sounds good and fine, but interestingly, Mark Philippon looked at patients at 10-year follow-up that had FAI surgery, comparing those that had FAI surgery with debridement versus repair, and in all reality found no difference between the repair and debridement group at 10-year follow-up. Now, whenever I review the data about labral repairs, I take this study into account that we did at Stanford. I had 6 intraoperative videos that I sent to 35 high-volume international hip arthroscopy experts, and I said, would you repair this or would you not repair this? So they're all looking at the same videos of labral tear. This was one of the videos, and we're probing it so they can see exactly what the tear looked like and to probing. Interestingly, in half the patients, there was agreement. There was 2 that everybody said we should repair. There was 1 that everybody said we shouldn't repair. And then there were 3 that half the group said they'd repair and half said not to repair. So it's not quite clear when you're looking at the data when somebody's saying what their success rate of repair is whether or not they are repairing the same things that I might repair or that you might repair. So it's there's still, I think, better need for sorting out what should be or should not be repaired. Labral augmentation people have started to do when you have a small labrum but an intact labral chondral junction. So a labrum that might be smaller than the normal size, maybe you lose the seal, and so the goal would be to put some more tissue there to reinforce it. Biomechanical studies have shown that a smaller labrum is associated with decreased distance to suction seal rupture or loss of that suction seal and decreased peak negative pressures. And so people will take some tissue there and place it. They figure that if you keep the normal labrum intact, then you're maintaining a normal chondrolabral junction, so that helps prevent the fluid from leaking out from the articular cartilage. You're preserving proprioceptive mechanoreceptors. It can improve the suction seal, and it's been shown in the lab that compared to reconstruction, it's actually better than reconstruction at maintaining the suction seal. You can use local tissues. Some use capsules, some use rectus femoris. I tend to use a graft, particularly I tend to use an allograft. But there's really minimal data in the literature, no long-term studies, only one comparative study itself. Most people use it for revision surgery, but there is a case series about looking at midterm improvement for revision surgeries. And then when it's been compared to reconstruction, it seems to be better than reconstruction. So again, maintaining normal your tissue. If it's irreparable, then people, do you just leave it alone or do you reconstruct it? Again, reconstruction is replacing the tissue to mimic a labrum itself. Some people will just fill the gap with a tissue. Some will actually take out the entire labrum and reconstruct the entire labrum, even the part that's normal. People have used different types of graft sources. It doesn't restore the normal labral conjunction. You don't maintain the mechanoreceptors, but it does help deepen the socket and provide you some stability. And so whether or not it restores function in the lab, looking at the suction seal, an intact labrum is always the best. Repair seems to be better than a reconstruction, and a reconstruction and laborectomy works similarly. And when you look at the effect of labral reconstruction, a partial laborectomy, you have decreased contact area and increased contact pressures. With a reconstruction, you restore the contact area, you decrease the contact pressures, but it's not normal or intact. And so does it restore function? A recent study came out from Chicago, showed it does, that a reconstruction has decreased intra-articular contact area and loss of suction seal compared to repair. So again, would suggest that repair is better. Just briefly, the indications are not clear. Most people do it as a revision operation. Some people will do it for primary. I don't think there's much evidence that that's the thing to do, but there are people out there doing it. Mark Philippon's indications are hip pain with an intra-articular etiology and an irreparable labral tear with disrupted longitudinal fibers, a small labrum, poor quality tissue, and that they've already had a prior laborectomy or scar resection, but the results are poor when they have some arthritic change. My indications, an irreparable labral tear. I'll do it primarily if somebody's got borderline dysplasia and I think that they need some tissue there, so for instability. They can't really have arthritis. I like to use a rounded graft, and again, I tend to use an allograft. A very unique thing for me here is that I'm actually presenting, I'm going to put up here, this is my son's paper that he published. He did a systematic review of labral reconstruction, and it shows that the labral reconstruction can improve postoperative outcomes, but there's no superiority over repair. There's probably some benefit over just a resection, particularly when you look at conversion rates to total hip arthroplasty, but we still need more midterm and long-term follow-up studies. But the outcomes tend to be quite good, even in athletes, but poor if they're older, have arthritis, but we still need more research. So in summary, if there's a tear, normal bony anatomy, no instability. If it's repairable, repair it. If not, you can debride it. If they have borderline dysplasia and it's irreparable, or if it's repairable, repair it. If there's good tissue but small, you can augment it. If it's not repairable, I think reconstruction is reasonable. So the labrum is important. It can regrow. Save it if possible. Again, I like to use a vertical mattress suture, keep the knots away from the articular surfaces, and growing evidence for the benefit of reconstruction. So thank you. So I apologize, I was a bit long. I actually just put that together after I left San Francisco to come here because I was asked late to come give that talk, so I apologize.
Thanks, Mark. So we'll continue, Mark. I think you're up next speaking about hip instability.
Yeah, so next one will be on hip instability, which is a bit of a controversial topic, if you will. But I'm not going to talk about dislocations. I'm going to talk about microinstability, if you will. So some people say that you can't have instability without dislocation, but we used to say that about the shoulder 30 years ago as well, and I think that that's not the case. For more detailed information, we've written a lot about this since 2011, about the concept of hip microinstability as it continues to evolve, and I think it's now pretty accepted. So what is hip microinstability? It's extraphysiologic hip motion that causes pain with or without symptoms of hip joint unsteadiness, or what I basically say is symptomatic laxity, kind of like we talk about in the shoulder. And even though people say, well, the hip is a ball and socket joint, in all reality, the femoral head moves relative to the acetabulum. So we did some work with the folks from the Rizzoli Institute and showed that the femoral head moves 3.5 millimeters in a medial lateral direction, 1.5 millimeters in anterior posterior direction, and 1.5 millimeters in a proximal distal direction as you take the hip through the extremes of motion. And if you look at the normal anatomy, you can see there is space between the ball and a socket. It is not a perfect fit. It's more like a gimbal joint than it is a true single center of rotation, if you will. And fortunately for me, when I presented that research, people thought I was crazy and said that's not the case. I said the data is the data. I may be crazy, but the data is the data. Fortunately, Jacques Menetre looked at ballet dancers. He had them do MRIs supine and then doing the splits, as you see here. And he shows that in asymptomatic individuals, they had 2 millimeters of femoral head subluxation relative to the acetabulum just by changing the position in the splits. And Josh Harris has also looked at ballet dancers, and he found 1.4 millimeters of femoral head motion, and 89% of his ballet dancers that he had doing the splits while taking an x-ray had femoral head lateral subluxation. This is a video reconstruction from Steve Aoki showing a patient using biplanar fluoroscopy that the femoral head also, again, moves relative to the acetabulum as the hip goes through range of motion. And so I do think a lot of this is guided by the ligaments, and Andrew Amos and his lab actually looked at the contributions of the ligaments to hip restraint and motion, and he found that the ligaments do play an important role in femoral head motion, especially rotation, and particularly the iliofemoral ligament, which is the biggest, strongest ligament in the body. And we find that either cutting or stretching the iliofemoral ligament and or capsule increases femoral head translation, rotation, as well as joint range of motion and laxity, and it's exacerbated by labral tear. So if you have a lax capsule and causal labral tear, the femoral head motion is greater than just having the laxity alone. If you have a normal capsule and have a labral tear, it does not increase your femoral head motions and translations. And so this is kind of the model that we think. Normally the femoral head moves relative to the acetabulum. You put more stresses on the labrum and the capsule. As you try to force more motion, what ends up happening is you get breakdown of the labrum and the capsule, leading to labral tears and more capsular laxity. That relies more on muscles then to provide more stability to the hip. The muscles will fatigue, and that'll lead to increased femoral head motion, putting more stress on the labrum and the capsular structures again, and it's a self-perpetuating problem. And so the real key to this is when people say, well, hip instability doesn't exist. Once you know how to examine for it, once you know how to look for it, you'll start to see that you'll see it a lot of the time. So I like to say the eyes don't see what the mind doesn't know. And if you're aware of what to look for, then it'll see you. It's probably seen you a lot, and once you start looking for it, you'll find it. So the history isn't so great. Oftentimes there's no history of injury. Sometimes they might have some microtraumatic injury. They don't complain of instability. Oftentimes they'll be diagnosed with Ehlers-Danlos syndrome, benign hypermobility syndrome, hip dysplasia, or borderline dysplasia. But one of the keys that got me started on this early on was a lot of these people that had normal bony anatomy. So Wenger showed that 87% of patients that had symptomatic labral tears had bony dysmorphology, and that was either FAI or dysplasia. So what about those other 13%? And I think those might have been patients with microinstability, if you will. So examination, we always assess for the Baton signs. We did not find that correlates, but certainly patients that are more lax might be more susceptible to having hip microinstability. We assess their distance of their lateral joint line to the table. As we said, is this person tight or loose? For me, again, I'm using my fist height. If it's my fist height or less than that joint line distance, then I'm concerned about laxity. So here you see this patient, the asymptomatic side, and then you see the symptomatic side. You can see she has more external rotation, and the lateral joint line is closer to the table on her right leg. Actually, if you just look at them when they're laying down and you examine them, you can see this leg versus this leg. The right leg's got increased external rotation. That's a sign of iliofemoral ligament insufficiency. So all your dancers are trying to get increased turnout, that they're stretching the iliofemoral ligament. And so you can also do a log roll test. So you try to internally rotate and watch it roll out and see how far it rolls out comparing the two sides, as well as springiness. We did a study recently that showed that while assessing the patient laying supine, if you add their hip flexion, internal and external rotation, and if they're a female and it's more than 200 degrees, they almost always have hip microinstability. If it's a guy and they have more than 200 degrees combined range, 75% likelihood of being diagnosed with hip microinstability. And this is being confirmed intraoperatively. So the tests, I showed you this test earlier. What we found with this test, it was our most accurate test for hip microinstability with 81% sensitivity, 89% sensitivity. When you look at the prone external rotation test, you have the patient lay prone, you externally rotate, put an anteriorly directed force on the greater trochanter. This test was described by Ben Dome. It was our most specific test in all actuality, but only a third of the patients had a positive sensitivity, but they had a 98% likelihood of having hip microinstability if that test was positive. And then the hyperextension external rotation test, as I showed you before, as well. And again, if you had all 3 tests, you had greater than 95% likelihood of having an intraoperative diagnosis of microinstability. If you had 2 of the tests, it was actually, it was 95% itself. Steve Aoki also does an axial distraction test like this. I think that's more a sign assessing for ligament the zona orbicularis, as well as suction seal effects, not the iliofemoral ligament. And then obviously when we're assessing somebody with instability, you want to make sure they don't have posterior instability as well, because most of this instability is anterior, the microinstability. Radiographically, you want to get your plain radiographs. If they have a center edge angle of less than 25 on their AP view, that's a sign of borderline of dysplasia. I get my Lequigné view also to see what their anterior coverage is. And then you also look at the so-called tonus angle or roof angle, as that's also a sign greater than 10 degrees with instability. But other things you can see are things like the anterior wall in this AP pelvis radiograph is sitting high, so that would, you'd pick that up on your Lequigné view, but that's a sign you can get on the AP. If they have excessive coxa-valga, if they have a narrow iliac wing, wide obturator foramen, are all things that you'll see in patients that have some dysplasia about the hip. We describe the so-called cliff sign. So if you look at the hip and you try to draw a circle around, as it comes around laterally and it just drops straight off, it drops off like a cliff. That's where that term comes from. So we've seen with instability as well. And you can actually see it on a lateral radiograph in some patients as well. It's not always just on the AP, but that has a high association with instability. Looking for more distal sclerosis and what you expect with impingement, as Paul talked about earlier. Gans talked about overcoverage causing it, but also you can have symptomatic impingement, if you will, from supraphysiologic range of motion. So your lax patients are going to have supraphysiologic range of motion. They're going to impinge more distally. So when you see distal sclerosis like this, that would be another clue about hypermobility, if you will. The splits radiograph that Josh Harris talked about, I don't do this routinely because most of my patients can't get in that position, but he had a bunch of dancers. So that's another thing that's been described. Martin Beck described the so-called FEAR index, which stands for femoral epiphyseal, which is a line from the femoral epiphyseal line, and then a line drawn along the acetabular roof. Gives you an angle, if you will. And he found that when that angle is greater than 5, it was more likely to be associated, borderline dysplastic patients associated with instability. And so, but again, this was specifically in borderline dysplastic patients, if you will. And so if there was less than 5, he thought that they were more likely stable, and therefore the symptoms more likely coming from impingement than it was from instability. We looked at a bunch of patients with this that did have dysplasia and did not have dysplasia, also compared instability versus FAI, and also found that the FEAR index is helpful in deciding if somebody has instability or not, but I don't think that number 5 degrees is consistent across the board, and I think that's been issues with other studies. John Sakian, the group at the University of Michigan, looked at 2 measurements on MRIs on the axial oblique. One is the space distal zona orbicularis on the axial oblique, and the other is the capsular thickness in that same area, and associated that with instability. They injected as much fluid as they could in their arthrogram. We only inject about 10 cc's on a routine basis, so we didn't find that volume made the difference of that space. But a capsular thickness was important. In women that had laxity, 85% of them had a capsular thickness of less than 3 millimeters on that axial oblique. Women without laxity, less than half had a capsular thickness of less than 3 millimeters. And if you took 3 millimeters as an absolute number, 82% of those that had a capsule less than 3 millimeters had laxity if they were female. And only 40% of women that had laxity had capsular thickness of greater than 3 millimeters. Other things, obviously, if you see a capsular defect like that, that should be a clue. Ligamentum teres tears. Not all the radiologists are reading the ligamentum teres tears, but we see that with instability. And so this was a study we did with Ian when he was at Stanford with me. We had 15 surgeons via Zoom from 7 countries. 6 of them were past Isha presidents. Average years in practice, 19. They'd been doing hip arthroscopy for an average of 18 years, minimum was 10, doing an average of 263 hip scopes a year. So high volume people that see a lot and treat a lot of instability. 69% did open and arthroscopic surgery. And so they've been treating hip microinstability for an average of 10 years. So this is a group that really is attuned to it. And they, on average, were performing 75 hip scopes a year for microinstability patients. And what we found out was when we were trying to figure out what are some of the clues intraoperatively for microinstability to confirm the diagnosis, ease of distraction of the patient's hip, the chondral injury pattern and location, the labral pattern, which is more of an inside out or wearing down of the articular cartilage with a labrochondral separation, and then the capsular thickness or quality, and then whether or not there's a capsular defect. All are signs for hip microinstability. So When we look at ease of distractibility, for my table, first thing I do when I do hip arthroscopy is I make sure that their perineum is down against the post. I bring the fluoro in. If they're already distracted, that's not normal. That's a clue right there that the patient has some instability. And so here we're doing an air arthrogram, and then after we do the air arthrogram, I take the traction off. And you can see sometimes they still stay subluxated after I've removed the negative intra-articular pressure in the joint. I think that if you think of the pathophysiology of the femoral head moving like this, what you see is that you get a labral chondral separation, and then you get this gradual wearing down of the articular cartilage at the rim of the acetabulum. This is a different pattern than what you see with hip impingement. With hip impingement, you're getting an outside-in phenomenon, and the articular cartilage is getting lifted off. This is getting worn down. And so when we look arthroscopically, you'll see a tear at the labral chondral junction straight anteriorly on the hip, or you see it straight laterally. You'll get that wearing down pattern right in that same location as the labral tear. And so this is one that you can see at 12 o'clock position or straight laterally. You can see the articular cartilage is exposed here just from being worn down. And this was a patient that had a high tonus angle. Other things we see is a chondral head damage of the central portion of the femoral head. So as Paul was talking about, loss of articular cartilage in the weight-bearing area is poor prognostically. I don't find that articular cartilage loss in the central head is as poor prognostically, but it does tell me that they have instability and we probably should be managing it. And then again, seeing a ligamentum teres tear like you see here is another clue. So how do we treat these? You can do it non-operatively and operatively. I think of this as I come to this from a sports perspective, not from a pediatric or arthroplasty perspective. I think of this very similar to the shoulder instability. And so we strengthen the periarticular muscles, particularly the hip and the core, and activity modification. We did a study looking at 64 of my patients that came to me for hip microinstability, or had hip pain that we thought was microinstability. Almost all of these were women. 70% insidious onset. Average months of symptoms prior to seeing me was just under 2 years. We sent them for formal therapy and a home exercise program for 6 weeks working on hip and core strengthening with a minimum 2-year follow-up. And what we found is that 35% were markedly improved, 16% were partially improved. Both of those groups did not want surgery. 19% weren't improved but didn't want surgery. And 30% didn't improve and underwent surgery. But when you look at it by athletes and non-athletes, half of the athletes ended up coming to surgery. As far as how else do we treat it, I think you've got to do it based on what the cause of the instability is, and there's a lot of causes. This comes from Josh Harris for the instability, but if it's bony deficiency, and particularly for me, if it's a center edge angle less than 17 degrees, I think they need a PAO. I don't think I can correct that arthroscopically. If they have excessive femoral anaversion, I think a femoral derotational osteotomy is the way to manage that. But if you think it's a capsular issue, and particularly that the capsule's lax, and particularly patients with Ehlers-Danlos and benign hypermobility or repetitive microtrauma, I think you can do a capsular plication. We started doing this with radiofrequency back in 2000, 2001. This is one of my patients with Ehlers-Danlos in 2001 that we just did striping, if you will, and actually it worked very well. And this patient I have 18 years follow-up on. She's done great, but everybody was concerned about the outcomes, and so we went to doing capsular plications. Mark Philippon did the thermal. Ben Dome talked about doing a capsular plication, and Chris Larson and Ehlers-Danlos patients. All of them had about 80% or greater good excellent results. I looked at a series of 32 patients. Those other studies had bony work done as well. I had 32 patients. I did just the capsular plication and labral surgery. Depending on how you measure it, a third to almost half had borderline dysplasia. And we basically had no reoperations, no increased symptoms, no loss of motion, and all the athletes returned to sports. And so basically I take out a piece of the capsule between the iliofemoral ligament and ischiofemoral ligaments, what I call the rotator interval of the hip, and I basically just do a plication like that and tightens those equally. If they have a defect, as you see here, I should not see in this revision case the iliopsoas like that. That goes along with this MRI. Then we go ahead and just do a closure of the capsule, repairing the capsule back down to the acetabulum and closing that space back down. So in summary, hip microinstability is real. We're able to diagnose this better preoperatively now as well based on examination and radiographs and MRI. They're not just your Ehlers-Danlos patients or dysplasia patients. You want to treat the underlying cause. You start with rehab. All the plication studies have good, excellent results, but we still need more data. So thank you.
Thanks, Mark. And it's my pleasure to introduce our final speaker in this block. Callum McBride is an orthopaedic surgeon joining us from Birmingham, and he is going to share some ideas about hip dysplasia and the athlete. Thanks so much, Callum.
Thank you very much. Thank you very much, everybody, and thanks very much for inviting me to the wonderful city of Edinburgh. It's been a fantastic couple of days, so thank you very much. Got slides? Yeah. Okay, so I'm going to be talking about hip dysplasia, particular reference to the athlete. I've got no particular disclaimers of relevance to this. So this is a message that I want for all of you to really, this is the most important thing. Please, can you just consider hip dysplasia as a cause? Because the problem is so much of our focus is on labral tears or FAI, that's the fashionable stuff. But actually hip dysplasia is a real problem that we keep missing, and we keep a disservice to our patients. And it's much more common than you think, and we all think of hip dysplasia being of babies, but it's an adult condition and is surprisingly common. Clearly in the sporting population, there are certain groups of which having a flexible hip, either through bony deficiency or, as we've heard from Mark, a soft tissue deficiency or instability, can be of benefit. So we have our ballet dancers or our gymnasts, but we also see it in martial arts. But it occurs in all sports in which excess force is placed across the hip, and I've got a number of rugby players who actually have bony dysplasia. So if you've got a patient, then we also, with groin pain, we also know that there are certain risk factors which may mean that they're more likely to have hip dysplasia. So if they're female, if they're the eldest sibling, they've got a family history of young hip replacements in their family, if they were breech position at birth, and if they have associated hypermobility syndrome, which we've heard from Mark. So please, they're such an easy group of questions that you can just ask your patient with groin pain. So just, can you play the sound?
I'm as naked as they come, taking pride, I'm not the kind to run.
As a dancer, flexibility feels like a superpower. I think flexibility has been a big thing for me in that way, and I've used it to my advantage.
Pick me up, 'cause I'm not as strong as I look, and I need you the most.
So at what point do we need to intervene in this patients? And I think it's really important that these patients are fully informed about the implications of their condition. For them as a performing athlete, they may wish, once they know what their problem is, to continue if they can. But really, what happens with these group of patients is they'll often present with mild symptoms that are affecting their performance, and they can be rehabbed, and they are often very good at managing the condition themselves. But with the associated rehabilitation, people around them, then they can often perform and continue to perform at a very high level. But eventually, if they've got significant bony dysplasia, it will catch up with them. So the ones you really need to be aware of are the ones that keep coming back. So they have the symptoms, they get better, they go back to their activity, 3 months later they come back. Those are the ones that you need to be thinking, is this dysplastic? And as we've already heard, MRI is not the investigation of choice of dysplasia. It is misleading. You need to have an X-ray in this group. And the number of patients that I've seen who've come to harm because they were falsely reassured by an MRI, which didn't give them the diagnosis of dysplasia, is too many for me to recount. So it's an X-ray or CT with 3D analysis. MRI is coming as a diagnostic tool, but it's not quite there yet. So hip dysplasia. So we've heard the marker of 25 degrees for center edge angle. Of course, this is a spectrum, and it's a mixture of bony dysplasia, three-dimensional anatomy, and soft tissue instability. And it's our assessment of that that's key. But in order for us to discuss and categorize, then we have some definitions, and those definitions are largely agreed. So the center edge angle, just so that everybody should know and see what it is a measurement with a circle placed around the femoral head and some angles drawn to the edge of the acetabulum. I think everybody here should at least know that, and if not, they should, hopefully many of you will be able to measure that and record it and document it. We also use the acetabular index, which is a measurement of slope. Now that, if we can only just do that as a profession, we will help many, many more patients. But it is more complex than that, and here's an athlete of mine whose X-ray was normal, but they had all those features that Mark presented, of pain and difficulty with continuing with their performance due to groin pain. They had a labral tear, they had inflammation of their psoas, they were over-recruiting their hip flexors in order to try and stabilize their hip, and they'd had endless physio, endless injections. And what their problem was that they had anterior insufficiency and a labral tear. But we are getting better with technology to understand, and we often have mixed patterns. So this patient has both a mixed pattern of hip dysplasia and FAI syndrome, or CAM morphology. And so the more we can understand about the anatomy, the better. And Rowena, you'll be delighted to see. Oh, it didn't play. I'll go back. Will it play? I want to check. Can you play that? We have the ability to, because we're surgeons, to rotate, which I have to say as a surgeon is really useful for me to understand where the problem is and what might be the right treatment if we decide to do surgery on these patients. We're at the point now where this is actually an MRI, but we're getting pictures like a CT, and so everything that you've seen up to date, which involves radiation, hopefully we're not too far away being able to avoid radiation in this group of patients or limit it. So that's all well and good. The patient, the athlete, they just want to get back to playing. But and quite rightly, they may decide after counselling that they don't want to have a surgical operation. That is their choice. But they should be informed about, well, what's their options if it's left. And we now have quite a lot of evidence about what is the natural history of dysplasia in difference to what we know about FAI syndrome or CAM morphology. In formal hip dysplasia, if you have a centre edge angle of less than 25, you will need, or likely to need, a hip replacement 1 in 3 in 10 years and 2 out of 3 by 20 years. So it's a really, really bad condition. Now, the patient may choose that. So I've got a number of athletes who say, okay, that's fine. I just want to finish my career if they're able to. But in doing so, they may reach a point that the surgical options that I'm going to talk about might not be available for them, but that is their choice. And here is a case example. A patient who had an MRI elsewhere, didn't have an X-ray, and was told they've got a labral tear, it can be managed non-operatively. So then they presented 6 years later with worsening pain, and by that stage they'd got some degenerative change when I saw them, and we agreed that they would continue with non-operative management because there was no other surgical option at that stage other than to have a joint replacement, which they went on to have in 2016. So I think it's really, really important. We have an obligation to educate ourselves, but we also have an obligation to educate our patients. I really hope that you can download this booklet, which is available from the Royal National Orthopaedic. It was put together by 2 excellent physiotherapists who themselves both have hip dysplasia. So the questions that we need to know for the athlete is, are they able to continue playing to the level they want? Are they able to train? And how is it impacting their life? If they're a professional athlete, this could have huge implications for them and obviously the club. Unfortunately, my experience for patients who are in elite level is that there's often a delay because of denial that this is a real problem and that they've got better with the previous rehab they've done, so we'll just give them some further rehab. And that does lead to significant delays in diagnosis of 8 years, and unfortunately that means that by the time they get to us, they've already got arthritis, when we could potentially have changed the course of them by doing something else. The other question I need to know is the expected duration and level of their remaining career. What's the realistic expectations? When do they want to retire? So these are all really helpful questions. And of course, when dealing with this group of patients, the psychological impact for them is huge. So we really have to spend time spending a lot of time building up trust with the patient and their coach about what their different options are and what does that mean for them in their sport. So decision-making in this group is very difficult, as we've already heard. Non-operative may be the most appropriate for that patient, but there are surgical options, and of course that is a team decision between myself as the surgeon the physiotherapist, the radiologist, and of course, most importantly, the patient. So we've seen hip arthroscopy, which is one option. And the other option for more severe dysplasia is a pelvic osteotomy. Now, that is a big operation and a scary operation, and it's one that terrifies patients, terrifies most of our referrers. We're getting better at doing this, and we can now, we're starting a trial in our centre where we are computer planning these and having specialised jigs that will allow us to accurately correct and predict the range of movement that the patient will have at the end of healing. And of course, that's of great relevance to your dancers, etc. And what's the evidence for our surgical treatment for dysplasia? Well, Mark talked a little bit about hip arthroscopy. I find, from my personal view, this is a paper which they talked about a centre edge angle of between 18 and 25. And of course, you know, it's a spectrum. There's soft tissue instability here as well. And my personal view is about 20. Once it gets below 20, then I'm personally into the world of osteotomy. But it's a debate, and there's no exact consensus. Now, what does return to sport? So 75% return to sport, but unfortunately, that is often not the sport that they were doing at a high level before. And only 45% can get back to the sport at the same level. And so obviously that's of great disappointment to the athlete. But the reality is, by the time we're getting to talk about surgery, they're already unable to do their sport. So although their career may be over, there's a 45% chance we might be able to keep it going. But it takes a long time. It takes 8 months, and it's very sport dependent as well. So some sports involve lots of cutting, take a lot longer. And as Mark described, 90% will return to sport over time. Now, what about worse dysplasia? So this is where the centre edge angle is less than 20. Then we've got 20, 30-year studies showing that this operation really works. And we've also got outcome data from our registry, which Paul talked about, which shows these patients get significant improvement in their symptoms. So in summary of a lot of papers, a lot of research, long-term, this is the results. 75% will see clinically important differences, improvements in their symptoms. There's an 80% risk reduction. So if you remember, 2 out of 3 would need a hip replacement by 20 years. So we can reduce that risk by 80%. And it does really well. And it's much better for the young patient than having a total hip replacement because it will last longer and actually give them equal outcome. But unfortunately, it is a big operation. And the older the patient, the worse they do. And any arthritis, the worse they do. What about the outcome? And so these are 2 recent publications in the last year about athletes in doing this big operation on athletes. Now, in the North America, they tend to do a concomitant hip arthroscopy, which is not something that we tend to do in Europe. But in their report, they report at 70 to 80%, again, get back to sport, and a similar level as the hip arthroscopy group, interestingly, get back to the same level of sport that they did before. And of course, as you might expect, for a big operation, it takes a bit longer than the hip arthroscopy. But in actual fact, there's not a massive difference between hip arthroscopy and this big pelvic osteotomy in terms of the results.
Somehow I can still do everything I did before.
So Renee had a pelvic osteotomy.
I don't have to change my career or do anything crazy different. So I'm really happy about that.
Okay, so just to summarise, please, for all of you here, can you consider hip dysplasia in the athlete with recurrent and groin, and don't just hang on to them until they become arthritic. It's very important that we keep our patients on side and we involve them in the decisions that they make. And it is, of course, entirely their right not to have an operation. Surgical intervention has a return to sport of about 70%, and 50% will return to the same level with either hip arthroscopy or osteotomy. But the delay to diagnosis is the real problem for us as a profession. Thank you very much for your time.
Thank you very much, Callum. Yeah, can I invite all of our speakers up onto the podium, please? We've got 10 minutes for Q&A, so I welcome questions from the audience. Mark, you're also going to join, hopefully? Yeah? Yep. Good. So if you've got a question, please raise your hand. We've got a few roving mics. And Rowena, thank you very much. Lots of time for questions, folks.
Could I ask the panel about their feelings of injections in patients with suspected femoral tabular impingement syndrome? I know there's a great variability around the world as to whether patients with who've perhaps even had best practice physiotherapy have ongoing symptoms. Do the panel feel that those patients should exhaust all non-operative measures, including injections, both diagnostic, or do they feel that actually the injection of steroid would be a bad thing? I'd be interested to know how the panel feel about that.
Hi. Yeah, I think we're hearing more and more that corticosteroid is not good for collagen-containing tissues. So perhaps local anesthetic alone, purely as a diagnostic test, is the way we should be going. I don't know what the others think.
So, I mean, this is part of a bigger question that comes up in that if you had somebody that, well, I'll first answer your question. So I'll use a corticosteroid injection to get somebody through a season. So if you have an athlete that's got symptomatic hip pain that you think is coming from CAM or pincer morphology, if you will, and you've tried some rehab and you need to get them through the season, then I'll give them the injection to get them through the season. The question really comes down to, I did a study a few years ago that we just published looking at 4 years of Stanford athletes, and every Stanford athlete that had hip pain essentially came to see me, and we have the second largest athletics program in the country, so we have 936 athletes. And over that period of time, four-year period of time, I had 40 athletes that were referred to me for hip impingement, symptomatic hip impingement, if you will. I guess that's redundant, right? Hip impingement and symptomatic. And I was surprised when I looked back that I had actually only operated on like 54% of the individuals. I would have thought, hey, this is a bony problem, they're symptomatic, get them through the season, and they'll need surgery. And in all reality, that wasn't the case. And it's interesting because just a few months ago, another paper came out from Australia by Fitzgerald that looked at individuals that had, I think there were 60 some odd individuals that he treated with injection, a structured rehab program, and found at a several year follow-up that actually only 39% came to surgery. So I think, you know, part of it is trying to sort out where the hip pain is coming from. I think a lot of times people get sent to me with an MRI that shows a labral tear, but they actually have iliopsoas symptoms, if you will, and you rehab the iliopsoas and they get better, and so maybe it was never inside the joint itself. But even if you are convinced that the pain was coming from inside the joint and the rehab got them better, the question comes down to, since we know, as was pointed out, that if you have an alpha angle of greater than 83 and an internal rotation of less than 20, that you have a 25% time odds ratio increase of developing arthritis within 5 years. And Morris Tanist gave a study that showed actually a comparison where he looked at the risk of getting melanoma from sun, getting lung cancer from smoking cigarettes, and getting cirrhosis from drinking alcohol. The risk of getting hip arthritis with that alpha angle and internal rotation was significantly higher than the risk of getting melanoma, getting cirrhosis, or getting skin cancer, or getting lung cancer. So, I mean, the risk's very high, but the question is, you know, should you be intervening? Again, as I tell patients, I don't have an operation that prevents arthritis. I know some people say, oh, you should have the surgery to prevent arthritis, but the question is, if you have somebody that was symptomatic and you make them better, rehab-wise, I mean, is that a problem for down the road? You know, will they become symptomatic later? Will they maybe have more irreversible damage? Certainly, we've all seen patients that come to you and were asymptomatic until they actually have arthritis, and you look and they had, you know, horrible CAM anatomy, that sort of thing. So that's, to me, the real question as far as delaying and what is the effect of delaying care. Again, I'm not a believer of operating on an asymptomatic hip. I'm not a believer in that we're preventing arthritis because we just don't have any data to that. But I do think using an injection to get somebody through the season makes some sense.
Thanks, Mark. I'm just looking for hands in the audience for questions here. Rowena, while folks are thinking of their questions, you've got a room full of clinicians here. What's the number one thing that all of these clinicians can do to make your life a bit easier as a radiologist?
How long do we have? I would say, and I know you hear us hammer on about this over and over again, but just give us enough clinical information. So the quality of the report you get is directly related to the quality of the information that you have. So if you don't give enough information, you're not going to get an appropriate report back. So it's always hard. I'll sometimes see request cards that just say pain, and I'm like, I don't know where that is. I don't know what could be incidental on the scan. Is it lateral pain? Is it the trochanteric bursitis? But the reality is, I think all the radiologists and neurologists would agree, every hip we look at has peritrochanteric inflammation on the side. So, just a bit more clinical information.
You heard it here first, folks. Paul, please.
Can I add to that? At Aspetar, it's wonderful because we have the radiologist next door. So it's really easy to go to the radiologist, have a conversation about the patient and also the imaging, and that helps a lot. So I agree, clinical information.
Yeah, absolutely. If you've got a question, stick your hand up. Yeah, before you do, I'm going to ask one of Paul, actually. Paul, the conversation with your patients and their parents, young athletes, hip pain, how do you negotiate that relationship and help people understand what's going on without raising too much concern and anxiety?
Yeah, I think that's a really important question. And for me, as I've alluded to in my talk, the language that we use with young athletes and their parents is really important, because through that language, you can either create fear and the need for an intervention, or you can create an atmosphere where the parents and the athletes are comfortable with your care and with your the plan that you give. So language is really important. But I think also it's important to be honest. If you have a young patient with FAI syndrome, and as Mark has alluded to, we don't know yet the 80-degree, 20-degree, 80-degree and larger alpha angle, and 20-degree and less internal rotation is in the a cohort of 45 to 55. We don't know yet there's no prospective data in the young athlete with that type of morphology, but we need to communicate that to the athlete and have a shared decision-making discussion about where are we going with this. And part of that is also often the type of sport to continue with or not a conversation. That is sometimes a difficult one.
So my question was really just to carry on from that, actually, Paul. Can you keep that? First of all, to ask you then, if you do have those characteristics that are associated with the 25 times increased risk of osteoarthritis, even if you don't have symptoms, should they have treatment in form of surgery?
So the question is, the young athlete with a 80-degree plus alpha angle and an internal hip rotation of less than 20 degrees, should they have surgery to prevent osteoarthritis? No. We have absolutely no data for that intervention, so absolutely not. And but should we have a risk conversation about what might happen in the future? Yes, but we don't have data to support that. So no surgery for an asymptomatic young athlete with that morphology.
Thank you, Paul. I'm going to draw our session to a close today and encourage you all to grab a coffee and have a chat with our panel members and anyone who you've seen speak at the conference over the last 2 days, sorry. Please join me in thanking our panel, and we are back in 25 minutes for the final block of speakers, so please join us for that last session. It's one not to miss. Thank you very much. All right, folks. We're right on time, ready to get started for our final session of the day and of the conference. So I hope you've had a chance to grab a coffee or some kind of refreshment. We are in for an absolute treat this session. we're going to kick off with Lucy Gosling, who's going to share some of her thoughts on rehabilitation protocols for femoroacetabular impingement syndrome. Lucy is a consultant physio at the Royal Orthopaedic Hospital in Birmingham, and she leads the peripheral advanced practitioner team and specialises in young adult hip pain. So we're going to learn lots from Lucy. Thank you very much.
Thank you, Claire. And thank you, everyone, for coming to this last session, well, a couple of sessions in the day. I know it's the graveyard shift, so thank you for bearing with us. We're going to hopefully provide some information about rehab protocols. So I work mainly in the NHS, and I have probably a limited view of the whole pathway. So I've asked my colleague, Emma Batchelor, who is a consultant physio at the University Hospital Birmingham. She works in the Sports and Exercise Medicine Service there, and she also works at Bisham with the GB hockey team. So she's going to complement my talk with more return to sport rehab. In addition to my role at the Royal Orthopaedic Hospital, I'm part of the UK Physio Hip Network, which is a network of the big centres that do young adult hip surgery. And we've created a network of the physio leads at those centres. So we now have got about 15 leads where we meet regularly online to share collaboration of research, clinical scenarios, case studies. So that's been a really useful thing for me, and it's kind of bringing together some of the UK work done by the physios in these centres. So when I was asked to talk about rehab protocols, I started thinking about what do we actually understand by rehab protocols, and they're hugely varied. It really depends an awful lot on how we use that primary evidence and how that evidence relates to our patient populations. There's obviously a lot of evidence syntheses out there, and they are varied. There is often quite a lot of poor quality data in those syntheses. There's also expert consensus out there on FAI and rehab protocols. And there's also expert opinion on what we do locally with our individual patient groups. So we've got a real mix of evidence that feeds into our clinical decision making. And then we've got a different population. So we've got populations that are very sedentary in the NHS. I mean, that's probably a bit of a generalisation, but we've got some very different cohorts. We've also got some high-level athletes, which is probably where a lot of your experience lies. And within that, we've got different resources available to see those patients, different access to treatment, different waiting times. The availability of appointments in the NHS is very different. So we've got a huge variability in the factors that feed into that clinical decision making. And the demands of patients also are really important. So the expectations of patients, what they've read in the literature themselves. Patients are much more informed now than they used to be. So again, we have to take into account all those other factors. We've also got our own practitioner experiences. So, our preferences and how we treat, which again feeds into it. So this is a really important paper as a benchmark for everybody on FAI management, really useful thing to go to. This was produced by the ISHA team, so published in 2020, and it was a consensus on best practice for FAI. They used a modified Delphi technique, and it involved 19 members of the ISHA group, and they had a huge amount of clinical experience. So it forms a really good basis, and there's a QR code there just to go to look through it. Now, we pulled this into our UK population, and there were some areas that we felt didn't completely represent our population. Particularly, it was largely based in the private sector, so our waits for treatment and management are much longer. And probably one of the flaws in it for us is it didn't include much in the biopsychosocial approach. And I think that's largely because of the smaller times to treatment, where they didn't develop lots of other psychosocial issues. So the UK network have reviewed this consensus statement, and we've just produced some guidance locally for the NHS population. So I'm going to then now talk about the stages within rehab. So we've got conservative management strategies, we've got pre-op or prehab. Prehab might be very different for elite sport than it is for the NHS. In the NHS, we have a period of treatment for FAI and then often a wait before they'll have surgery. So prehab is often a separate entity, whereas in elite sport, I imagine it's more of a continuum of just conservative management. We've got post-op rehab, and then we've got return to sport, which Emma's going to talk about more. So what is the evidence in terms of FAI conservative treatment? We know about the large RCTs that have been done looking at surgery versus physio, and we know that surgery overall comes out as superior in functional improvements. However, there are improvements in the physio group, so we shouldn't forget that there are improvements. The difficulty is those protocols of physio haven't really been compared to each other, so we don't know what type of physio is better. And there's also some flaws in the physio protocols that were designed, and some of them are like 10 years old now, so some of our evidence about how we rehab has moved on, and we probably need to relook at some of those protocols that were included. But we do know that physical therapy, including education, activity modification, manual therapy and strengthening, show positive in the form of moderate to large effect size results for pain and function compared to injections where there were more small to moderate effect sizes. So we know that physio can be very helpful. And we also know that supervised, active and core strengthening is more effective than unsupervised, passive and non-core focused programs. And I think we all get that very clearly, and it's probably what we would do anyway. But we do need more research comparing the effectiveness of different conservative treatments, and patient selection is probably needed more so in this group to direct treatment. So I think it may move on that we need more subgrouping to identify which patients will improve, as has been done in other areas. And then more recently, there's been some evidence around injection plus physio, which gives beneficial results. And I know in elite sport that that's probably used a bit more commonly as a way of managing patients. So in terms of conservative strategies, we need to look at really what are the impairments, what are we trying to treat? So we know from the evidence there are a range of movement losses in terms of flexion, internal rotation and external rotation. We also know that there were muscle weaknesses in the flexors, extensors, adductors and in the lower trunk strength. And we also know that single leg balance and functional task performance is also down in this group. And so the Isha consensus talks about an assessment of the patients, which will probably include some of those things we've just talked about. Pain relief, obviously, just to get symptoms under control and to be able to engage with rehab, and education, so educating about movement patterns and how to not flare up that joint in order to maximise treatment. And in doing so, developing a hip-based programme. And that programme should include things like joint mobilisation, so they recommend posterior, inferior mobs for painful flexion, range of movement exercises in a non-irritating range, and strengthening, looking at neuromuscular and compensation strategies. And I think probably from a personal point of view in this group, and the problem probably with the literature is that you don't get an awful lot of detail, is that we see people are really tight into hip extension. So we tend to work quite a lot on regaining some of that anterior capsular mobility alongside some of those recommendations. Okay, so if we go on to prehab and looking at the evidence, so the UK Hip Physio Network did review the evidence on prehab as well, and we found really looking at levels 1 to 3 evidence that there was very limited research. And we only found one paper which was by Louise Grant and her team in 2017, and that was the HAPPY trial, which looked at hip flexor and quadricep strengthening preoperatively, and they did a one-off session of physio, and then they had 8 weeks of daily exercises, and they had good improvements in the hip flexor and quad strength and EQ5, D5L compared to a control group. So we definitely recommend one session pre-op, particularly in the NHS, because that's quite manageable, but obviously daily exercise is also recommended. And what I would mention in the prehab phase is hip flexor weakness is probably something that really needs focusing on. There has been some research looking at outcomes 2.5 years post-surgery, And they, in a number of studies, they found hip flexor weakness way down the line. So if we can start that hip flexor strengthening early on, it can be really beneficial. So this is just the general advice around prehab. So looking at advice, education, strengthening exercises, interventions for pain. We'd recommend starting some outcome measures in the prehab phase, just so you've got some comparison measures for post-op. And the UK Hip Network recommended the EQ5D5L and the IHOT12, which have been validated in this group. But there's no one single protocol, and really it does depend on, you know, all those things we talked about before that feed into how you make a decision about your patient in front of you. And definitely at least one session pre-op in the NHS. And then we move on to post-op rehab. So the ISHA consensus talks about looking at your surgical restrictions, and obviously this will really guide that first 6 weeks of post-op rehab. Structured physio has better outcomes, so making sure you've got a very structured plan to your program. They recommend 4 to 5 phases that are time and criteria based. So we've got joint protection in that very initial phase, not flaring up that joint. And what we tend to find from a very acute point of view is that if you flare that joint up in the first couple of weeks, it's really difficult to calm it back down. So really making sure patients are aware of, you know, what not to do, and avoiding really deep flexion is probably the biggest thing to be avoiding in that very early phase. The next phase is restoring range with control, moving on to strength, moving on to more dynamic control, and then moving on to more sport-specific rehab. Overall, you're looking at a time frame of 12 to 28 weeks of rehab. And again, looking at your outcome scores post-op. So again, IHOT12 and the EQ5D5L. If we look at the systematic reviews on protocols post-op, there's a huge amount of heterogeneity in the studies out there, and it makes it very difficult to bring together protocols. And that's largely based on the differences in the patient populations, how we diagnose FAI, the surgeon's techniques, the surgeon's post-op restrictions, the types of services those patients see physio in. So at the moment, there is a wide range of heterogeneity in trying to bring those protocols together. The UK network looked at that in more detail, and basically there's 2 RCTs that include the Tackler-O'Donnell protocol, which has shown benefit at 14 weeks compared to normal care. And we would probably recommend that as a protocol to look at if you want some more specific guidance. And the QR code's there for the Tackler-O'Donnell protocol. There's also a code there for the weight-bearing restrictions that you tend to find, which give you some time frames really on the different surgical procedures and how long they'll be restricted with weight bearing. Okay, so this is just looking at some of your milestones. So by 4 weeks post-op, you should be aiming for about 90 degrees asymptomatic flexion, about 10 degrees hip extension, 80% range of movement, and in some cases full weight bearing, but that may well be restricted by your post-op protocol. By 6 weeks, you should be looking at equal range of movement, strength 75% or above, single leg stand 30 seconds, and 1 mile continuous walking. And by 8 weeks, you're aiming to return to functional or an ADL restoration and a hip outcome score of over 85% on the ADL subscale. Now, this is again based on probably a more private population, and probably in our NHS population, some of those timeframes are a little bit fast, but it's a guide, and again, it's making sure that it's milestone driven as well. So don't base it all on timeframes. And so this just goes into a little bit of detail about the phases. So in that first phase, we're looking at avoiding that deep flexion, avoiding prolonged positions. We find patients that go back to work and are sitting for hours on end tend to really flare their hips up. So even sedentary positions, just try and avoid it for for more than half an hour at a time. Avoiding twisting is also advised in that early phase, mainly due to the labral compression and the forces that go through that labrum with compression and rotation. Also, muscle activation exercises are recommended, particularly with the Isha protocol, deep hip rotators. That's more Amir Takler's work that's been done on that. And again, for us, probably starting some really low-grade hip flexor work in a non-irritating range is really useful. Range of movement in that early post-op phase is really important. So from a personal point of view at the Orthopaedic Hospital in Birmingham, rotation and extension is really important early on. When we first started doing hip arthroscopies and we hadn't got a formal protocol set up, we had lots of patients that came back from other physio services and they hadn't really had what we'd call the best input that we would like, and they become really tight into hip extension and rotation. So we've seen that where we have very little intervention, and those are the patterns that patients get into. So just really gentle rotation exercises and getting them prone lying early on just to start lengthening out that hip flexor to neutral in the early phase is really important. Weight bearing with a flat foot, again, really important. So we found partial weight bearing and toe touch weight bearing can sometimes activate your hip flexors more and give you soft tissue irritation early on. And so again, just those little reminders to help reduce inflammation is really important. Hydro in the Isha consensus talks about 14 days, but we get them in the pool much earlier at the Orthopaedic Hospital, so within the first week they go in the pool. Soft tissue mobilization and restoring cardio is really important. So swimming with the pool buoy is really useful, and just really gentle on the bike, low resistance exercise just to start increasing cardio is really useful early on. Sorry, I have to go around the circle. So in the next phase, 3 to 6 weeks, again, just avoiding that deep 90 degrees flexion, compression loading, returning to therapeutic exercise. They talk about cycling a little later. Again, we would do it earlier, but it just depends on your patient. Proprioceptive training and strength. Hydro and deep water running. I think for NHS patients, deep water running at that point is a bit early, but again, dependent on your patient. Soft tissue mobilization is really helpful in this phase. And then we move on to this phase, which again is similar precautions, working more on endurance, global strength, unilateral loading, core stability, proprioceptive training, and then moving on to sport-specific training. And so return to sport, I will hand on to Emma in a second. And the issues really with return to sport is the variation in the types of sports and demands. And I think that's where we see the evidence starts to fall down a little bit. There are many case studies out there and case reports and expert opinion, but I think we need more data in more specific sports. In the evidence, we see return to running is around 12 weeks, return to sports is around 15.5 weeks. Again, like I've just mentioned, minimal high quality sports-specific FAI research is out there. Return to sport rates for physio-led non-operative treatments are actually not known yet, so even in the conservative management, we don't really have really good quality evidence. And return to sport rates post-FAI surgery vary between 57% and 90%, and that's largely based on case series level 3B to 4. Okay, so I'm going to hand over to Emma for the next bit. Emma is, as I mentioned, a consultant physio at the Queen Elizabeth Hospital, and Emma's also taken her GB hockey team through 3 Olympic cycles, so she has a huge amount of experience. So I'll hand over.
Afternoon, everyone. Thank you for the opportunity to talk a little bit about my sport. I've started off with the wider context because I think, for all of us, wherever we work in terms of any of our clinics, there's a wide demand of what we need the hip to do in terms of that sporting context. We've got Haaland on the end there, who's got a massive stride length, and he's quick, isn't he? And then if we look at taekwondo and rowing, very, very different hip positions. So I'm going to talk a little bit about my sport, hockey. So you can see within that, there is a lot of demands in terms of different ways in terms of how hockey players have to function. So from the point of outletting, in terms of the depth and range we need to get the hip into to perform that function, and then on to in terms of high-speed running. So the way we play hockey now is that very much about that high press, reactive running, and that sprintability. And then we've got the goalkeepers, whole different group. So then that kicking function in terms of what we expect them to do. So this is a little bit of context about what FAI looks like in terms of the hockey. This is the team data for both the men's and women's programs for the Tokyo cycle. So it's a 5-year cycle. It's kind of disrupted our data very much because we often look at cycle reviews, and 5 years is a massive hit in terms of what we got from Tokyo data. So you can see that the women's program had 8 instances of femoral acetabular impingement, and in the men's team, we had none in their top 10 diagnoses. The men seem to get a lot more soft tissue injuries. They have less issues in terms of that hip joint component. And I think when we look at the characteristics underlying that, so that was the 8 instances of FAI are in 7 athletes. And within that, their presentation was normally that they had imaging presented with a small labral tear and underlying that a cam lesion. We've got 1 athlete that has a very mild dysplasia. So they've been worked up, but they've all been managed conservatively. I don't have any surgical data for this group. We haven't had any recurrences yet, but we obviously have athletes that are still competing, so that's something we are very vigilant with. Okay, so the impact. So when we look at incidents, we then start to look at what does it mean. So as you can see on here, out of those 8 athletes, not all of them had time off pitch and availability. Some of them were compromised, and there were some changes in terms of their training load. But as you can see, this is our top 10 diagnoses for loss of time, and some of the stuff we talked about yesterday, particularly in that concussion remit. But FIA does not feature. But I think that just gives just part of the picture. What we're seeing when we look at incidents reported is often that top of the iceberg, what sits underneath in terms of that performance impact. So I think the message I've got is this certainly has an impact in terms of how our athletes perform, particularly our goalkeepers. But actually, in terms of time loss, is not one of our biggest issues. Okay, so we've talked a little bit about where we're at, but also about the why. So I work in a field sport where we've just talked about high-speed running and acceleration. So when we look at it in terms of these pie charts represent the joint components and the momentum of each part in terms of that propulsion. So the top pie charts are positive work, so that's acceleration, that's propulsion. So we can see in that the ankle has the highest joint moment, then followed by the hip. The bottom pie charts are around negative work, so they're on that braking and deceleration. So what we see there is that the hip has a higher component at faster debrake and deceleration activities. So I think we said this morning, wasn't it, Enda talked about that importance about deceleration and how we need to capture that in terms of our return to training and our rehab processes. I think the other bit for me is that you're rehabbing a hip, make sure you're looking at the ankle, because if you've got something that's actually not going to restore completely that hip strength, particularly with hip flexors, which we'll come on to in a minute, you need to make sure that you've managed that kinetic chain. We often think of the kinetic chain being the trunk and the pelvis, but actually ankle is really important in terms of how we get propulsion, particularly in field-based sports. Okay, so return to play. We use a criterion level, but with the reality in sport, there's always a timeline. There's always that ability for the coaches to ask, are they going to make this tournament? And that comes into, I'm not going to talk about where we get to in terms of decision-making within that. That's a whole different conversation in terms of where we start to take the give and also take relative risks in terms of exposure of athletes and availability with it. What we've looked at with Lucy is very much around that early stages in terms of that review, restore, and into that reconditioning phase. For the rest of this, I'm going to start to look a little bit more around that 6 weeks onwards, more into that reconditioning and into that return to performance aspects with it. I'm going to give some key principles. So a lot of this I try and transfer over to my NHS patients. I don't have some of the resources we have at Bisham Abbey in terms of how we rehab our GB hockey athletes. But I think principles are really important about how we rehabilitate all of our patients and our athletes. So outcome is really important. So if we're going to measure how successful we are in rehabilitation, we need to be really clear about what our outcomes are. We also use a VALD performance. It seems like VALD's have had very free publicity these last 2 days in terms of their systems. We know that the paper by Cadlick, which is fairly recent, they've looked at in terms of the reliability. So we've previously used handheld dynamometry. I use handheld dynamometry in the NHS. We know the reliability of the force frame is higher than that. So we're looking around acceptance, which is on there from the Cadlick study, and then higher issues in terms of handheld dynamometry in its reliability. So this is our normative data. Our normative data is very difficult to compare. So if we look at the Cadlick study, they did all their measurements at 60 degrees hip flexion. Comparable with how you use the groin bar, which is where they come from. We've come from using handheld dynamometry. So we end up looking at extension, largely because of being able to fix a handheld dynamometer onto a unit to give more reliable and the reliability of your testing procedure is really key in terms of how you work within any environment. On the left-hand side is our normative data. So this is women's programme data. The men have only started using the force frame over the last 6 months. We have about 96 sets of data now on female hockey athletes. The second column is around 20 athletes that had hip pathology, so not just FAIS, just across the hip pathology. And what I think you can see in terms of on here is when we look at trying to normalise, there's a wide capture, and that's largely around where they are in terms of that restoration phase and what's happened in terms of that hip pathology and tissues that we're waiting to settle to test. But I think what you can see is that we don't struggle too much in terms of regaining adductor peak force. Abductor's a bit lower. We struggle more in terms of that hip flexor. And part of that is at these stages, we've not exposed them very much to that high-speed running. So do we need that to help us get back to our normalised data? Or is it we're just not great in terms of that hip rehab, which is what we've seen in terms of ISHA consensus and the UK Hip Society consensus as well. So I've got some questions there. That's one thing that we're looking at the moment, see if we can get that better and earlier. Okay, we use leg extension ISOs. So the extension stuff we find very difficult to do on the valve performance. So we actually just use force plates. We look at a baseline of 1 times body weight, that's male and female hockey athletes. The data I presented before was data that's newtons. We normalise all of our data, so we put it against newtons, kilos, metres, wherever we can. So it actually helps comparison across the group, because if you've got an athlete that's 5'2" versus your 6-foot athlete, it's not really fair to compare, isn't it, in terms of their force production and what's normal for them and across the group. Okay, if we were talking about the ankle, we would definitely be talking about peak force production, and we'd also be looking at capacity, so we're doing ankle calf work. As I've alluded to, if I haven't got access in terms of force frame and if I haven't got time sometimes in terms of the handheld dynamometry to do it well, Copenhagen testing is a really quick way to get a value and looking at where they're at from a capacity point of view. We spoke about it yesterday in terms of its use in injury prevention, but we know actually that it's also extremely good in terms of improving strength for both hip adductors, but I also think we forget it's really good for hip abductors as well, as we've seen in the Shaver study. Okay, so this is by no means what we do completely in terms of hip rehab. This is just a few examples and just to take through about what we're considering. So with all of them, we're trying to look at isolated hip peak force measurement and actually trying to get some isometric work through it. Within it, and also, we're starting to look at what do we do. So from the rotations here, we're starting to look at what's our passive range of motion like and what's our active range of motion like? So are they equal? Is there a mismatch in terms of that? Wherever possible, we know from the ISHA consensus, it's about lumbopelvic strengthening as well. So the picture in the middle is hip isometric using banded work, but equally, it's in a position of actually starting to get some more trunk control. When you look at the side here, this is a goalkeeper. She's doing an isometric. This exercise for the hip is an isometric adduction exercise. But in terms for a goalkeeper, the ability to use the upper limb and have that braking and that deceleration to come on off the ground is hugely important. So an early introduction to all of these things starts to get to us in terms of where we're looking from a performance planning and a return to performance. And all of it all based on what do we find, where do we know their previous injury history is, where do we know that we need to get to them to actually get them quicker and faster onto the pitch, particularly if timelines are really crucial. So there's a few more pictures here. I don't know if any of you are aware of like Igor Tak's work. We talked about with Lucy around that range in terms of that hip here, so trying to get into the depth at the front foot, as we've seen in the hockey pictures, and also that extension range. We've got that aspect of actually getting range back through that trunk. And then if we look down here, this is an isometric abduction exercise. We've also nicely brought in some lumbar-pelvic control in there. And again, just looking at that hip abduction range, hip lift here, down into adduction, in an isometric calf iso. So again, trying to how do we capture all these things together? Athletes don't like spending long in rehab. They like to get back out in terms of, they've got conditioning sessions to do as well as this. So actually, if we can be more efficient in how we expose them to it. So the only other key principle here for me is about that lateral aspect. It's a change of direction sport. We need to really make sure that in cutting sports, we're also adding in that lateral aspect to it. Okay, and there are times where we get to retain them, so we've got them through that reconditioning, or actually during that rehab phase, we've looked at their ability, what irritates the hips. So we've talked about with some people, they get some residual restrictions. So if we look up here, if we look at the incline leg press, can you see that the trunk difference from there to there has a very different effect on the hip? Knee, not so much, isolated, but if you look here. So we might need to think about positioning for what they do in their normal gym program. Might be actually you choose to do something different, like the horizontal leg press, or you can even go up into standing and actually just look at what are you trying to capture within your strength program and how can you adapt around it. A quarter squat here, so we often see people that talk about, I want to get back to a front squat. Your options are, you could limit the range, go heavier, go for a quarter squat, and you'll still get that development of explosive force. Or you could use a safety bar, because the safety bar itself will stop that limiting in terms of range there. So that's about retaining, that's about the future. So once you've taken them through, how do we monitor these athletes? How do we keep them in terms of performing as they wish to do? So, take-home points. Very much what Lucy said. So all of this is relevant in sport with all of our patients in terms of making sure that we're good at returning range. We're evaluating all the time. We're looking about what the reaction is from post-operatively or in the conservative ranges from that. We're looking at rotational. We're very much looking about our baselines and that restoration. The bits I would add on is that we really need to remember is that we ensure we're really clear about what our strength markers are in relation to the sports that we are looking at, all the athletes we're trying to rehabilitate. Again, range is crucial, but it actually could be combined range and not just isolated hip extension. How does it work in terms of the trunk? Think lateral for change of direction sports. And don't forget the ankle if you're involved in acceleration. I think what Lucy and I both wanted to say is to acknowledge everyone we work with. We come up here to present, but very much this is about the multidisciplinary team and about how we all interact together to get through to it. So both surgeons, sports medicine doctors, physios, our imaging teams, and also the strength and conditioning, and most important, our athletes that we work with. Thank you very much.
As our next speaker comes up again, a round of applause for you all for staying to the end for the most exciting part of this entire conference. And I also, again, want to give a shout out, if you will, to Ian for organizing this and his organizing committee, including Andrew and Patty, for putting together a great meeting. And congratulations again for the UK Collaborating Centre on Injury and Illness Prevention in Sport being here in Edinburgh, and Bath. So congratulations, you guys. So for our encore performance, the penultimate discussion and presentation, Paul Dykstra about the Yahir collaboration.
Thank you very much, Mark. Thank you, everyone, for staying until just before we all need to get to the airport or wherever. So this is about the Young Athletes Hip Research Collaborative. You might have all wondered what Yahir stands for. That's what it is, Young Athletes Hip Research Collaborative. And in the next 7 minutes, I think, this is a call to collaborate, really, around conditions that are important for the young athlete's hip. I have no conflict of interest. And this is a screenshot from our website in development. So hopefully this will launch soon. We partner, and that's what we want to do, partner to promote and protect athletes' hip health through high-quality research. That's the focus. High-quality research that will filter into clinical practice to improve outcomes for young athletes. and I've made it bigger there. Yeah, here is an international collaboration of multi-professional stakeholders with the objective to increase value and reduce waste through better research on conditions affecting the young athlete's hip, including the etiology and prognosis of bony morphologies, as we've discussed. Our community aims to improve outcomes for young athletes and patients with hip conditions. And this includes a community. The word community ecosystem is really important. And you'll see that not only are we clinician researchers, methodologists, and including radiologists, orthopedic surgeons, sports physicians, and physiotherapists, but importantly, also patients, and also athletes and coaches, and parents of young athletes. So this is who we are. I'll say a few things about the research that we've done and not published yet, and also the events that we had and events coming up. So the Oxford Consensus Study Part 2 was an important project for the AHEAR Collaborative to prioritize and rank where we should go with research in this community. This was published earlier this year, and there's the QR code if you want to download. It's open access, published in the British Journal of Sports Medicine. And we ranked 18 research statements and combined those statements in 7 important research domains. The first research domain, best practice physiotherapy. And I have to say there that we revisited that terminology, best practice physiotherapy, to read clinician-led incremental exercise rehabilitation. That's a better word than physiotherapy-led or best practice physiotherapy. Because in other parts of the world, and in many parts of the world, it's not only physiotherapists that lead rehabilitation. And a lot of good work in this domain being done by Joanne Kemp, Professor Joanne Kemp, La Trobe University, and I think the PhysioFirst data will be out soon. So watch this space. And Joanne is a keen member of our AHEAR Collaborative. The second domain is rehabilitation progression and return to sport. With all its difficulties and with everything that return to sport might mean, and Claire is an expert in the room on return to sport in athletes in general, exercise intervention and load management, the third domain, primary camophology, etiology, and prognosis. As I've alluded to this morning, or this afternoon, a lot of work needs to be done in that space. FAI syndrome, etiology, and prognosis, diagnostic criteria for the morphologies, but also the conditions that we see, and finally, screening. A lot of uncertainties around should we screen for primary camophology in the young athlete. And we've discussed this at the meeting that I'll just mention after this. And screening should be done within a research project and not outside research. If you want to read more, this is a figure from the paper. There's more detail in the paper. So in September last year, we came together for the first time face-to-face in Oxford at the Young Athletes Hip Symposium and Research Meeting, where we discussed these 7 research domains, and we're finalizing the Oxford Consensus 3 paper at the moment based on the conversations we had in Oxford on the research priorities. We had support from British Journal of Sports Medicine and JOSPT that we are really grateful for. And the next symposium and research meeting is 18 to 20 September 2024. So this is an invitation to everyone who wants to contribute, who want to collaborate. We will meet from 18 to 20 September 2024 in Oxford, and it will probably be a conference, a 2-day conference and a research meeting. I'm going to end with 2 more slides. One study that I'm really proud of is this one, More Value, Less Waste in Research on Primary Camophology and its Natural History, a qualitative interview study of stakeholders' perspectives. This is, will go out for review soon. And 5 action-inviting themes came out of this research. So take a photo, but don't share it because it's not published yet. And those 5 action-inviting themes include putting the athlete and patient central to research, involving them right from the start and throughout, including the dissemination process. But also aspects like embracing open science, championing equity, diversity, inclusivity, and nurturing young scholars. Really important for us to nurture and develop young scholars and clinicians. And a shout out to Claire and JOSPT Insights and Dr. Josh Heary, who is driving the collaborative initiative between the HERE Collaborative and JOSPT around podcasts for conditions around the young athletes hip. And this was the most recent podcast in that series on hip dysplasia by Drs. Inga Mecklenburg and Julie Jacobsen. Really brilliant podcast by Josh Heary. And finally, I think I've counted 9 of 11 research centers, IOC research centers, are involved in the HERE Collaborative. So an open invitation to anyone in the room who wants to collaborate in any of these. This is not a club, this is not a closed door thing, this is not a political party, so everyone really welcome to collaborate and work. So in summary, Young Athletes Hip Research Collaborative is the HERE Collaborative. We prioritized 18 research statements in 7 domains for hip-related research, 5 themes for immediate action to improve research quality in the field, and that's probably what we will be discussing next year in Oxford, how to action those 5 important themes. I've mentioned the 2nd Young Athletes Hip Symposium in Oxford next year, and the fact that we involve individuals from 9 of the 11 IOC research centers. And again, huge thanks to everyone who's been involved in many ways and different ways. I have 5 supervisors in my PhD project. They are all there in this picture, and many other collaborators through the pandemic and ongoing. Thank you very much.
Thanks, Paul, and thanks everyone. We have time for a couple of questions. If you've got some burning questions, we have roving mics hanging around. So anyone wants to check in about return to sport after hip, or for athletes with hip pain, what's new in the research world around hip pain? Paddy's got a mic waiting. Pop your hand up. Yeah, I see. Is that a hand at the back? No, that was a stretch. Okay, I can see. I can see a question just down here. Thanks, Paddy. That's great. And actually, I'll invite our speakers. Thank you. If you come up on the stage, we'll grab some chairs for you.
There's one for you.
Thank you for all great presentations. So about hip pain, you only talk about FA impingement. And do you consider any rehabilitation program in which for an asymptomatic elite athlete with labrum tear and a softened cartilage? So a swimmer with labrum tear and a slightly pain, which has been decreasing.
Asymptomatic athlete.
And also for Dr. Mark, if you want to give his opinion.
Yeah. So I think the question was about
we have and
the label and for cartilage defects.
Yes.
Yeah. So
just, was described just a softened cartilage, not a big defect, such a slight softened cartilage.
So obviously it would depend on terms of what's gone on in terms of the orthopedic and the operation sort of procedure with it. So generally, principle-wise, that restoration phase will include what any constraints there is from that, and will be guided in terms of from surgical guidance following surgery. But actually, once you get out of that restoration stage, I would argue that generally your outcome measures and what you're looking at in principles is the same as that we've gone through today, is very much looking at your sport. Is there any consideration in terms of needing for constraints around range in the future, or can you progress them all the way back in terms of their full function. And that's what you need to do. So I think it's very much, to me, it's about principles in terms of what do you know about your sport, your athlete, individual athlete in front of you, what do they want to get back to, what have you highlighted as your strength measurements, and within that, what's your timelines that you're looking to do with it? Because I think the thing about the opportunity of working in sport versus the NHS is generally sports people, that's their full-time job. They may have some part-time aspects, but for the rest of the population that works in and has a full-time job as well as rehabilitation, your timelines are going to be slower. But I think if you're really clear about your criterion and you go very much more around the expectations of the patient, if the patient wants to get back to something quicker, they have to do the work to get to that point. That's my view in terms of rehabilitation. Rehabilitation takes work and commitment from the patients.
The only thing I'd say is, again, since there's such a high prevalence of asymptomatic labral tears, you can't always just attribute it to that. I find it very difficult, and at least the radiologists that I've worked with at Stanford, because of signal-to-noise ratio, it's really hard to get a good look at articular cartilage. I know Rowena showed some nice T2 mapping. We played with T2 mapping and T1 row for quite some time, probably my first 6 or 7 years at Stanford, and haven't found that as useful, and degenerate has its own issues as well. So seeing softening and, on the MR is kind of a softer call, if you will. At the time of surgery, I certainly see softening of the articular cartilage, but if it's not delaminated, I leave that alone because I can't make anything in that place better than what it is, and I can only try to remove what I think might be, if it's impingement, and remove the offending factor, if you will. Certainly you'll see cartilage hypertrophy in dysplasia, but it really comes down to the symptoms. If they don't really have symptoms coming from the joint, and if you send them to rehab and they have no symptoms, and they can go about doing all they want, let them go do about all they want. If I tell them, though, if they clearly have an alpha angle of 65 or so, and they're asymptomatic, I just say, pay attention to your hip. If it does bother you, don't ignore it for a year or two or whatever. Because one of the things I didn't mention earlier, so I looked at my study, I did a study of just my college pro and Olympic athletes, so a very defined group that I knew was getting back to sports, the goal was to get back to high-level sports. And we had 88% return to the same or higher level of sport. When I looked at, trying to look at all the different factors I could, that was a predictor. The only thing that I found associated with those that were unable to return to sport versus those that returned at a lower level versus those that returned was the length of time they had symptoms before they came to surgery. So I'm not advocating for as soon as they have surgery, operate on them, because again, over half of them, or about half of them, I can get better with just rehab. But the patients that had that were unable to return to sport at the same level had symptoms on average for 45 months, so almost 4 years. The ones that were able to get back, but not at the same level, had symptoms on average for 26 months. And those that were able to get back had symptoms on average for 15 months. Now, in that group, I have an NBA player who had symptoms for 10 years before I operated on him, and he did get back to the NBA, so it's not like an all or none phenomenon. But it's clearly, I think, the longer they are symptomatic, and it wasn't based on the degree of pathology, intra-articular pathology. I thought it might be, but it definitely wasn't. And certainly Mark Philippon and Michael Sansone and Göteborg have found the same thing. The duration of symptoms does seem to correlate. So I tell them not to ignore it, but but if I can make them asymptomatic in rehab, great.
Thanks, Mark. And we're highlighting the beauty of the multidisciplinary team here with the physiotherapist, the sports physician, and the orthopaedic surgeon all working together to answer the questions. So congratulations to all of you. I've got an organiser's prerogative question here. Andy, to you.
Thanks, Claire, and 3 fantastic talks. Thanks so much. Paul, I wondered if you could just share again those key points that you had from the qualitative work that seemed to me to be very applicable to not just the young athletes' hip work, but also just to wider research.
Yes, I'm very happy to share those. As I've mentioned, it's going to be published soon, so don't tweet those 5 themes. But the first theme is we should do research with the athlete and patient in the center, and collaborating, partnering with athletes and patients right from the start, creating the research questions, doing the research, disseminating the results, and following up. So that's the first one. The second one is embracing open science. and everything around open science. That means open data sets, open publications. Two aspects that were highlighted in this study was the cost of publishing open science and the problem of predator journals, not necessarily in this research field only, but I think all over. So open science and everything around open science. The third is authentic collaboration, and everything that authentic collaboration might mean. The fourth one was embracing equity, diversity, and inclusivity. As we've heard this afternoon, we need much more research in girls and women as participants in research, but also women in research teams. Those two prospective cohort studies, that brilliant studies, but it's men only in the team. And I was part of the Warwick Agreement, 21 men and 2 women. We're changing that, I think. So that's the EDI agenda. And the final one is podium young scholars, nurture young scholars. So those are the 5 action-inviting themes that came from the qualitative study.
Thanks for sharing those, Paul. I'm going to give the last word to Lucy and have your reflections on what you've heard from Paul around engaging athletes and patients in the work that you do as a physio and as a researcher, all of the work that you shared with us earlier on. Your reflections, Lucy. I know you've thought a lot about this.
I think mainly there's just a real lack of research engaging patients' voice, and I think that's what I would really say is needed in this group. You know, we have all our experiences of what we feel patients need, but we don't really know what patients want, and I think that for me is the biggest thing that's come out of this. That's why we need to push the research.
Fantastic. I can't endorse that more. Thank you, Lucy. I think that's a wonderful place to end the panel discussion. Please thank me in joining our panellists and speakers. And Ian, I'll hand back to you.
Thank you to those of you who've stayed for the bitter end. We'll just keep you for a few more minutes if that's okay. I have the pleasure of announcing the winner of the poster presentation. So Emily Hemming, whose poster on a video analysis study of team ice sports in Canada, a comparison of body checking and head contact rates to inform injury prevention strategies. If you're still here, if you'd like to come up and collect your certificate. Well done. Great. And I also have the great pleasure, on behalf of all of the 4 presenting partners, that's Edinburgh Orthopaedics, the Royal College of Surgeons of Edinburgh, the UK Collaborating Centre on Injury and Illness Prevention in Sport, and the University of Edinburgh Sport, in thanking all of our speakers for contributing to our programme and for joining us in Edinburgh. We're very grateful for all of your support. And to thank you for all of the delegates that have joined us. It's great to have had your support, for all of you in person and also joining us online. Thank you.
Yes, and thanks also to everyone who's been moderating the session so well and taking up so much of your time, of your time. So thanks again to the college for hosting. Thanks for all our sponsors, and I'd like to thank the organising committee, which is a big organising committee. We had Heather, Andrew, in particular Paddy. I want Paddy you to stand up and embarrass you for a lot of work behind the scenes. Andrew Murray, Niall and John McLean. So thank you to you all for being so interactive and for investing so much time in it, and hope to see you back in Edinburgh sometime soon.